lovely Pongal, and here we are in TNFOG Imaging Series, which is an online monthly webinar meeting. And today's series is on 20th January 2024 between 5 p.m. to 7 p.m. On the session Facial Anomalies. So this is mainly the effort is Dr. Sampath Kumari ma'am and Dr. Malati Prasad ma'am, who is the director, Trichy Fetal Medicine and Fertility Center, and she's won the first prize for paper on fetoscopic skin biopsy in epidermolysis in the conference in 2011, and she's won the best paper prize at Foxy 2015. And she's a famous consultant, as we all know, from Trichy Fetal Medicine Center. And she's authored many publications and books. And ma'am, I welcome you to start the program. So let us start with Tamil Thai வாழ்த்து. To invoke God's blessings, let's have the Kuttu Velakku lighting. So welcome address by Sampath ma'am.
Radhika, leave it, no problem. Radhika, thank you.
Thank you, ma'am.
Good evening to all. I welcome you all for I think this is the 5th series of the Imaging Science Committee, the chairperson being Dr. Malati Prasad of TNFOG. TNFOG, we have 10 committees. One of the committees, Imaging Science Committee. Malati is doing a wonderful work. She has done 4 series, one with first trimester anomalies scan, second trimester scan, RH negative, and another one, Malti, it is case discussion. That was the first discussion. So every month, third Saturday, we have from 5 o'clock to 7 o'clock Imaging Science Committee webinar. Now today, she has taken the theme as facial anomalies. The wonderful speakers throughout India, they will be giving the talks and panel on this imaging science. So thanks to Dr. Malati for this wonderful webinar. I wish you the success. And for all the webinars, our coordinator, MOC is Dr. Radhika. Thank you, Radhika. And thanks to our president and the entire TNFOG team. Dr. Malati, you can take over.
Yes, ma'am. Madam, thank you very much. I must thank Dr. Sampath madam for inspiring me every day, every other day to do something on the TNFOG series. So she's literally pushing me. So thank you, ma'am, for all the mentoring and all the guidance throughout. We're planning to release a book after 12 months, maybe in the month of September. And that book will contain all the talks which have been delivered over the TNFOG series. So today we have exemplary speakers Dr. Lakshmi is a your speaker. She's done so much of work on face and palate. I have no words to express my thanks to you, Dr. Lakshmi, for joining in. So I request all the members to take this opportunity to learn from this stalwart. We have many speakers, Dr. Navya, Dr. Revati, and Dr. Manigandan will be joining at the end of the session. So with this short introduction, I think we go on to the chairpersons.
Okay.
Dr. Radhika.
Yes, ma'am. Thank you, ma'am. Thank you very much for involving me as well. Thank you, ma'am. So we are going to the chairpersons. I invite Dr. M. Tamil Selvi, ma'am, who's a consultant, Arul Hospital, Trichy, and Dr. Akila Vaidyanathan, consultant, Lalita Nursing Home, Trichy. Dr. Tamil Selvi, ma'am, is alumni of Madurai Medical College, and she's done MD in Stanley Medical College. She's got the gold medal and university first in DGO and MD. She's a very active member of Trichy OG Society, and her field of interest is high-risk obstetrics, vaginal surgery, and endoscopy. And she's a consultant from Arul Hospital, Trichy.
From tomorrow, she is the president, Radhika, for Trichy Society. Very soon.
Welcome, ma'am. Congratulations.
Thank you, madam.
Tomorrow she'll take over as president of Trichy OG Society.
Malati is very happy than me.
Yeah, so excited.
Okay.
Yeah.
Dr. Akila, ma'am, from Ramachandra Medical College, and she's done her master degree in Obs and Gynae from Anomalies University, and diploma in cosmetic gynecology at Indian College of Cosmetic Gynecology. She has underwent training at World Laparoscopy Center and Kiel School of Endoscopy. She's a EC member of Trichy OG Society and a faculty of UVA Foxy, Trichy and Salem TNH. And she has presented papers at national conferences. And she's from Lalita Nursing Home, Trichy. Welcome, Dr. Akila. And Dr. Ma'am. So moving on to the first topic, angles and views in fetal phase by Dr. Navya. Ma'am, kindly introduce Dr. Tamil Selvi, ma'am.
Welcome, Dr. Navya. I am very happy to participate in today's program.
Thank you, ma'am.
Navya did her MBBS from Chengalpattu Medical College and MD from the PGI Chandigarh, and trained in fetal medicine under Dr. Anita, Apollo Center of Fetal Medicine, New Delhi, and Professor Kypros Nicolaides in UK. And she is certified specialist in advanced fetal neurosonography from Dr. Karina Hart, Israel. She is certified specialist in advanced fetal echocardiography. She is also certified specialist in clinical genetics. Her main areas of the clinical interest is aneuploidy screening, preeclampsia, growth restriction, multiple pregnancies, genetics, many awards and many papers. Welcome, Navya. Now she is the senior consultant in fetal medicine, Yashoda Hospital, Hyderabad. Welcome, Navya. We are eager to hear from you.
Thank you for the very kind introduction, ma'am. I'm just sharing my screen.
Navya, before screening, sharing your screen, when did you do in Chengalpattu Medical College? Which year you finished?
Ma'am, 2004 batch. And I finished in 2010.
10.
Yes, ma'am. Sorry for the delay. Can you see my screen, ma'am?
Yes, yes.
Yes.
Yes, yes.
First of all, good evening, everyone. I heartfully thank all the dignitaries present in this forum and giving this opportunity to me, especially Dr. Malati ma'am, and also my dear person, Dr. Revati Chandrasekharan, for this opportunity. And if I'm not wrong, most of us are fetal medicine specialists attending this CME today. And we have a practice of seeing around 25 to 30 new phases. We are familiar with phase. But what I found while preparing this topic is that there is no adequate data in the literature where any practical method or reference value is given. So I tried my best to concise all this vast topic into a 20-minute talk. So all the experts present here might know most of the things what I'm going to say today. If not, at least a single practical point you might get from this topic, or it could be a good revision for you as well. So moving on to the topic, we know that fetal phase is an essential source of information. Its evaluation makes it possible to diagnose several fetal diseases and syndromes. So early detection of this facial abnormalities may lead to the diagnosis of multiple syndromes, which allows counseling of the parents and optimal care of the fetus. The 3D and 4D ultrasound, which has become a recent advance, have become essential complementary tool to the 2D routine ultrasounds and provide additional and more precise information about the presence and severity of facial defects. So before moving on to the topic, I want you to just brush out the memory on the embryology, because understanding the embryology is very important as how a normal anatomical variation occurs with timeline, that is a fusion, invagination, detachment, etc. of the structures, and series of variations are due to this complex biochemical and genetically assigned events, which the genetic events are studied and understood better at this point of time in this era, and any deviation from these naturally occurring events can cause congenital deformities. So starting from the embryology of external phase, the structures which are important for the external phase formation of frontonasal prominence and mandibular maxillary prominences. This frontonasal process formed by the proliferation of mesenchymal and neural cells from the ventral to the forebrain, and this mandibular and maxillary prominences are parts of the first pharyngeal arch. And next comes the medial and the lateral nasal processes. The two medial and lateral nasal processes fuse in the middle along the lateral and the lateral maxillary and the lateral mandibular processes to form the nose and the mouth. So thus the development of the face derives from frontonasal process, which forms the forehead, bridge, and the dorsum of the nose. The medial nasal prominence forms a nasal septum, philtrum, primary palate, and upper four incisors and associated jaw. And the lateral nasal process forms the lateral sides of the nose, and the maxillary process forms the cheeks, upper lip, and the secondary palate and lateral upper jaw. And mandibular helps in development of the lower lip, lower cheek, and the jaw. So just brushing up the idea of embryology of eyes, it starts as a cavity in the forebrain as early as 25 days of gestational age to form, and later it evaginates slowly to form an optic stalk or optic vesicle. Later, at the same time, the surface ectoderm forms a lens placoid, which invaginates into this optic vesicle and forms a lens vesicle. And this surface ectoderm later forms the eyelids. And it starts, as I said, as early as 25 days, and it takes at least 9 months for the complete formation of the eyes. And the ears at the same time starts at as early as 6th week as a 6 auricular mesenchymal hillocks, which appears as 3 on either side of the first brachial cleft or the groove. And during the 7th week, the external ear, that is pin of the ear, takes its adult shape. So this is a concise summary of the facial development. It starts as early as 3rd to early 4th week, and various series of events occurs. And by the end of the 12th week, that is during the period of an NT scan, the complete face is formed, which look like a mini human face. And even the ossification centers of all facial bones are formed by 12th week. So what are the views of face which we routinely use? There are many views and planes along which the prenatal scans are done to diagnose the fetal anomalies. Most commonly used planes are the sagittal plane, axial, transverse plane at the level of orbit, maxilla, mandible, coronal or frontal planes. These are the usually used planes. And the standard views of fetal face as described by the higher borders like ISWOG and FMF UK, they recommend only basic planes as a standard and essential planes for mid-trimester, that is the early TIFA, or early trimester scan, that is NT scan. Like ISWOG only recommends around 3 facial planes and in the first trimester and also in the second trimester. FMF UK suggests around some 6 to 7 planes where the TIFA scans must have all this images, all these views while doing a TIFA scan. These are the minimal requirements for a TIFA or a NT scan. That is, out of 22 plus 2 views, which has been recommended as a standard views by this higher borders, three planes are only for the face. So if we restrict our scanning images or anything, we might miss out the minor or subtle abnormalities and may land down into lawsuits and sometimes cost a lump sum both professionally and financially. So we have to have our own checklist to find out all the possible structures in the face, which includes forehead, ears, eyes, nose, etc. In the next consecutive slides, I'm trying to concise things so that it is easy to understand and easy to practice. So starting with the profile view, in the profile view, we see a forehead which is linear normally, and immediately above the articulation between the nasal bones and the frontal bones, and followed by a smooth backward bend, and we see a nasal bone and nasal soft tissue and upper lip, maxilla, secondary palate, where we can see the superimposed sign where there is a presence of omer bone and oral cavity and inferior lip and chin and this is the mandible and the chin. All this should be in a same plane, and each and everything should have a specific measurements, which will be discussed in the following slides. And next is the axial view, which is commonly recommended, one at the level of orbit. At the level of the orbit, we can see the orbits and the paraorbital area. We should know when paraorbital area is also very important, because we can rule out whether there is any presence of abnormal structures like dacryocystosis or tumors. And we can also see the lens, which is transparent, or there is any kind of a cataract in the cataract. And we can see the nasal bridge. And in this view itself, we can measure interocular distance, binocular distance, and ocular diameter. And the nomograms, these are the nomograms starting from as early as 11 weeks to 40 weeks. I'm not going to go into depth of everything because the time is very constrained and it's a very vast topic. So next standard view or recommended view is the axial view at the level of maxilla, where we can see we have to see whether there is a upper lip continuity is there or not. The maxilla, which is usually appears as a regular U-shaped, is there or not, which appears brightly echogenic, and the alveolar buds or hypoechoic, which should be, there'll be no shift between the adjacent alveoli. And next is the hard palate, which appears as an echoic structure with a complex shape. The anterior part is semicircular and the posterior part is a rectangular figure with a notch in the distal end. And here comes the soft palate and the uvula. This view also helps in the measurement of size of the maxilla. So for the soft palate and uvula, a slightly oblique mid-sagittal plane is used, and also axial and coronal views are used. In this mid-sagittal section with ultrasound beam, when it is insonated inferior below the chin, which helps in the visualization of the soft palate, including the uvula and the tongue, the most commonly known sign, the equal sign, can be seen for the identification of uvula. In the frontal or coronal section, through the same insonation, if we take a 3D imaging, or if we focus that in the coronal section, we can see the pharynx here with the visualization of a uvula as an equal sign, and the opposite to that is the epiglottis. In the transverse section also, we can visualize the uvula. So next comes your oral cavity, which can be visualized in the axial view also, where we should be able to notice the tongue occupying the totality of the oral cavity, and it should be glued to the alveolar ridge. It should not be outside, or it should not be very much inside, which helps in this feature, which helps in the diagnosis of whether there is any macroglossia or there is macroglossia. Posteriorly, the tongue ends in the oropharynx, and the oropharynx with the epiglottis. This view also allows in the measurement of length and width of the tongue, as I already mentioned. The next level is the mandible level, where in this axial view, we have to note the continuity of the lower lip and whether there is a mandible, which is a hyperechoic V-shaped structure, is seen or not. Both the hemimandible should be rectangular in rectilinear, and the symphysis mentae should be clearly visible. The alveoli inside this mandible appears as a regularly distributed hypoechoic spots, and this view also allows a measurement of the size of the mandible, the mandibular width or computation of the mandible width and maxillary width ratio, which I'll be discussing it later. And the next is the coronal view, where we should be able to see the two nostrils, upper lip continuity, lower lip, and the chin. So in the first trimester, the same profile view or the sagittal view gives additional information or additional information where we can see a forehead, the nose, mouth, maxilla, chin, nuchal translucency, and the other internal structures like thalamus, brainstem, fourth ventricle, choroid plexus, cisterna magna, and occipital views. Mainly, we focus only for the face today. And in the coronal view, which is taken at two levels, at the level of the orbit, where we can get additional information of orbits and lens, maxillary process, and the nasal bones, and the anterior aspect of the maxilla with the alveolar ridge. And where in a quite oblique view, we can see the retronasal triangle, where the nasal bone forms a superior border, the frontal process of the maxilla forms laterally, and the alveolar ridge forms inferior border of the triangle. And this two lateral body or the mandibles with a mandibular gap, which is very important to differentiate between whether there is a presence of any micro or retronecrias. The axial view in the first trimester gives the same information as we see in the second trimester. That is, the orbits with lens, frontal process of the maxilla, and the nasal bridge can be clearly visualized in these views. So one should not forget about the ears, because the studies have shown that the incidence of 1 in 6,000 newborns being reported for external ear malformations, and ear abnormalities are important in the diagnosis of variety of congenital malformations or syndromes in newborns. So, for example, the reduced ear length is most consistent phenotypic characteristics of neonate for diagnosis of trisomy 21. So, a dedicated examination of fetal external ear must be done with him, and it is very imperative. The views recommended in various literature are the transverse inclined view at the level of cervical vertebral level, mandibular level, parasagittal view, and coronal view at the external ear level. This is a mandible level, parasagittal level, and cervical vertebral view. So at this parasagittal view, we can also measure the ear length, the apical part of the helix to the caudal part of the earlobe. But the range of fetal ear measurements in the healthy fetus from gestational age of 17 to 30 weeks is around somehow 10 to 40 mm. Even though the measurement of the fetal ear auricle is possible, but its clear clinical usefulness for prenatal management is currently very limited. So none of the paper expect us or recommends to measure the ear length, but because ear abnormalities are related to variety of syndromes, which I'm not going to discuss each and everything, it is very important at least to look into the ear, how is the size, whether there is a position is normal, and what is the shape of the ear at least. So the checklist of fetal face should include mainly all the 7 important face structures like forehead, nose, maxilla, mandible, ears, orbit, and eyeballs, lip, and palate, which can be covered in variety of views. Take it a profile view, coronal view, transverse view, or we should be able to assess every important checklist here so that we can have a better knowledge of what we are going through. If at all there is any abnormality, or if whether it is normal, or whether there isn't any abnormality, so that we can actually get a diagnosis clearly. So if we couldn't take any kind of a view, now there is an advancement of 3D and 4D assessment, where there is an acquisition of those 3D volumes in the fetus, allow a detailed assessment of facial anatomy. If we couldn't take any kind of a profile view or sagittal view, make sure that you get at least one 3D image saved for every fetuses, so that later post-processing can be done to take a particular view which we want, like be it a multiplanar, omni view, or a TUI. And same can be done in your first trimester also. Like we can take a multiplanar images, TUI images, omni view, For example, in this, at the level of the nasal bone, if we couldn't see the exact axial view of the fetal face, by taking just a 3D view, at the level of the nose, we can see the nasal bridge very clearly in this 3D assessment. And likewise, the chin can be very nicely seen here, and at the level of maxilla. So the 3D images helps in the post-processing when we couldn't take when the fetus is not in position, or when there is a patient is very obese. So just a 3D acquisition helps in the post-processing. So not only for the views of all the facial structures, we can also use this for facial bones, that is skull bones and sutures also. This 3D technique can be used for a better understanding of the anatomy of the fetus. So coming to angles and face, which are also called fetal facial profile markers, the sonographic diagnosis of the facial abnormalities are done routinely till date as a subjective measurement, which might result in some error in the diagnosis. For a higher sensitivity and accuracy, various objective techniques have been introduced to help better define facial abnormalities in utero itself. This objective diagnostic methods can be indices, which is a direct measurement, or can be a facial angle or observational characteristics. So this objective diagnostic method provide a normal reference values for a prenatal early detection, early diagnosis, adequate time to counsel and prepare the patients. So starting from maxilla and mandible, which is most common abnormality we encounter here is a micrognathia or retrognathia. So there are more than 30 biometric parameters related to the mandible, out of which 15 are obtained as a simple and conveniently taken. And we can draw a diagnostic criteria or a warning value for micrognathia from this parameters. Those are in the forms of angles, where 5 facial angles are most easily taken for prenatal diagnosis. When we go for a direct measurement of a mandibular biometry, usually they have a significant correlation with the gestational age, with a big changing amplitude throughout the pregnancy. Hence, these are usually compared with the cross-sectional centile charts or calculated as a ratio, like example, jaw index, negative FP line, or mandibular gap absence. And next comes your, based on this method, that is either angles or direct measurements of mandibles, we can take a diagnostic criteria or warning signs, where clinician can quickly make a preliminary judgment on the facial deformities to carry out a cytological examination to further clarify the diagnosis of micrognathia. I'm not going into details of all the 15 parameters. I'm going into the main important 5 practically useful and easy ways to diagnose the angles, so that it can help in the derive a diagnosis of micrognathia. So first, starting with inferior facial angle, which is usually drawn as a line orthogonal to the mandible, forehead, drawn at the level of synostosis of the nasal bone, and the line drawn through the tip of the mentum, usually in the upper lip, so that the normal mean value of this angle is 65 plus or minus 16 degrees, ranging from 81 to 49. The value of less than 49 gives a diagnosis of micrognathia. It is a very sensitive and specific angle. The positive predictive value is around 75 and the negative predictive value is around 100%. Next comes your frontal nasomental angle, which is drawn as an angle between the line drawn from the tip of the nose towards the frontal bone, and the other line is drawn towards the mentum. The intersecting point gives the angle, which normal mean value is 147 degrees, ranging from 140 to 152, and less than 142 is diagnosis of micrognathia. It is a low positive predictive value because many fetuses may have a nasomental angle below the fifth percentile. So according to the recent literature, the FNMA angle in pathological cases ranges between 100 to 134. So next, we'll see about frontomaxillary facial angle, that is the FMF angle. This is actually an angle drawn between the maxilla and the forehead. And the normal fetus is quantified at 85 degrees plus or minus 10 degrees. And a wide FMF angle is reported in the fetuses with a trisomy 21, whereas a narrow FMF angle is noted in open spina bifida. So this abnormal FMF angles are also reported in fetuses with trisomy 18 with mid-facial hypoplasia, which was likely due to a short maxilla or a micrognathia, and also in fetuses with trisomy 13 in association with holoprosencephaly. So a caution should be used in evaluation of this FMF angle because a slightly oblique insonation, oblique views will introduce a false positive or negative results. So the measurement of FMF angle using a 3D multiplanar rendering technique has been shown to improve the accuracy. So narrow FMF angle, as I already said, it is seen in spina bifida, mainly maybe due to smaller flat head owing to the posterior shift of the brain and also decreased fluid in the ventricles. So next we'll see about mandibulomaxillary facial angle and also FMF angle and also MMF angle. So the first line of the FMF and the MMF angles coincide and it extends on the upper surface of the palate. The second line for this MMF angle, because we have seen already the FMF angle, the MMF angle second line goes downwards to the upper corner of the mandible. It is negatively correlated with the CRL, while the FMF, this ratio, FMF-A and the MMF-A ratio is independent of CRL. So many studies have been conducted by major authors who also found that the ratio of FMF-A and MMF-A are very practically easy, simple and useful technique, and it is very convenient to identify the micrognathia. So, and ratio of this FMF angle and MMF angle should greater than 0.75 should be used as a diagnostic criteria for micrognathia during the prenatal examination. So next we'll see about M&M angle, which is the angle between the lines drawn from the maxilla, nasion and the mandible in the exact mid-sagittal plane for evaluation of the anterior and the posterior relationship of the upper and lower jaw. This is actually independent of gestation age and CRL. And many studies have been conducted, which says the mean is around 13.5 in the mid trimester and 12.4 in the late trimester. So some studies says that it is very, very smaller and the mean value is as low as 9. So caution should be taken while measuring this M&A angle to assess the micrognathia. So what is recommended is this M&M angle greater than 14.2 should be used as just a warning sign, not as a diagnostic criteria for a diagnosis of micrognathia. This M&M angle is large in the presence of micrognathia and retrognathia, or combination of this, and is small in the fetuses with trisomy 21. So next we should note about FM angle, which is facial maxillary angle, which is an angle drawn from the maxilla and the line across the upper lip and the mentum. So the normal range of FMA angle is narrow with a lower limit of greater than 75 degrees. And many studies have been conducted to say about what is the mean value. So they have all concluded that the FMA angle less than 75 degree as a warning value and FMA 66 degree as a diagnostic criteria for micrognathia. And next come to the here I end up with the angles. I start with the indices. First is the jaw index, which is calculated after measuring the anterior posterior diameter of the fetal mandible at the level in the axial plane. It is referred as a percentage of the biparietal diameter. That is, this is a technique was derived as lateral growth of the mandible even in the micrognathia appears to be relatively normal. Only the anteroposterior diameter is seen to be reduced. So this anteroposterior diameter is the distance between the symphysis menti and the middle line, which is drawn from the bases of the two rami. So, as I said, the jaw index is the AP diameter of the mandibular diameter by biparietal diameter into 100, which is independent of gestation age. So the mean value is 19 at 18 weeks and 35 at 28 weeks. So totally a cutoff of around 23 mm, that is below 2 standard deviation, is taken as a diagnostic criteria for diagnosis of micrognathia, which has a positive predictive value of around 69% and negative predictive value of around 100%. Next, let's see about the mandibular width by maxillary width ratio, which is very important parameter again. So, which is obtained as in the axial view, which is taken from 10 mm posterior to the anterior osseous border, both from the maxilla and also from the mandible. And the ratio is found to be constant over the second trimester. The mean value of this ratio is 1, and any value is less than 1, that is less than 0.78, is used to define the micrognathia. So coming to mandibular length, this parameter is adjusted for gestational age or fetal biometry, which is another sensitive and reliable prenatal method for assessment of fetal jaw development. The specific charts are given for the mean, with the mean value -2D, that is 5th centile and 95th centile, across gestational age and also female length. Here I use the gestational age chart. So the mandibular length is measured from the symphysis menti and the temporomandibular joint, and the increase in the mandibular length is almost linear with the increase in gestational age and varies approximately 20 at 18 weeks and 37 at 28 weeks. And the measurements below the 5th centile is suggestive of micrognathia. So all the parameters and indices and the observation characteristics which I have discussed in the previous slides, I have concised in the one table so that for easy reference. So this, the more common chromosomal abnormality with micrognathia occurs in trisomy 18 and triploidy. And there are also variety of conditions where this micrognathia can be seen. This is a list of common conditions, and the literature says that the incidence of chromosomal abnormality with micrognathia is around 50 to 75%, and associated anomalies is around 80 to 90%. So when we see a micrognathia in an antenatal prenatal scan, we should have a detailed ultrasound to look for other associated anomalies, and also we should offer the patient for an invasive fetal testing. So next, let's see about the maxillary length, which is most commonly seen when we see a midfacial hypoplasia. It is measured from 11 to 14 weeks, and it is validated for midfacial hypoplasia. The measurement is performed in slightly a parasagittal view and includes a mandibular joint, that is the maxilla. This is the condylar process, ramus, and the mandible. At this plane only, we should measure the maxilla. And it is short in fetuses with trisomy 21. And the maxillary length increases linearly with the gestational age by around 0.1 mm for each 1 mm increase in the CRL. So for 2021, 95% of cases, the difference between the two consecutive measurements, that is, if you measure in the 11th week, the 12th week, this two consecutive measurements will be less than 0.47 in T21, which is expected to be around 1 mm per week. So next, let's discuss about nose, where the important angle at the level of nose is the nasofrontal angle, which is used in the diagnosis of flat nose. The studies have demonstrated the absence, hypoplasia, or depressed nasal bone associated with trisomy 18, Appert's Lane syndrome, and in particularly trisomy 21, which is measured between the nasal bone and also the frontal bone in the mid-sagittal plane. So the normal range is 110 to 143 with a mean of 128 between the gestational age of 18 to 21 weeks, and an angle greater than 143 degrees is a suggestive of Binder's phases. These are the other conditions with the similar Binder's phases, which will be discussed in the next session. So in the forehead, we have facial profile line, which is commonly used for the diagnosis of frontal bossing, micrognathia, or microcephaly. This facial profile line passes through the midpoint of the anterior border of the mandible and the nasion, and the frontal bone may reside behind this FP line, which is called the negative FP line, and extend frontally, which is called positive frontal facial profile line. In euploid fetuses, the FP line is at 0 or mildly positive. It is negative in microcephalic and trisomy 18 fetuses, and strongly positive if there is a frontal bossing. The position of this FP line normally changes with increasing gestation because after 27 weeks, the forehead assumes a more rounded shape. So this facial profile line in Down syndrome, due to small mandible, depressed nasal bone, and a prominent forehead, it is more positive FP line. And in achondroplasia, it shows the protrusion of the frontal bone. There is more frontal bossing, so there is an increased FP line. But in cases of micrognathia, where the anterior border of the mandible resides back. So there is a negative FP line where you can see the frontal bone is behind this FP line. So it is called a negative FP line. So in microcephaly, with or without a normal mandible also produces a negative FP line. So this should not be confused with the prefrontal space distance, which is actually measured between the forehead and the line drawn from the anterior aspect of the mandible and maxilla. This is normal. In normal fetus, it is quite short, this prefrontal space. And in case of a facial cleft lip and palate, it is increased. And in case of micrognathia, it is very much increased. So there are so many literature which has shown the dimensions of fetal facial profile in normal pregnancy. For example, the minute of the measurements, like from the tip of the nose to the mouth, from the mouth to the chin, or all have been given. And the normograms of each from the varied gestational age from 15 to 27 weeks, they have given many measurements. This all help in the diagnosis of abnormal facial structures in the second trimester. So this, all the angles and the indices and also the observation methods which have been discussed earlier can also be applied in the first trimester also, because our search of anomalies has been shifted to early trimester to benefit the easy of first trimester MTP if there is any need of it. And all fetal facial profile markers mentioned earlier, as I said, can be assessed during this earlier pregnancy scans also and are validated with respect to CRL and gestational age. So now, if we are not able to acquire this angles, indices manually, now an artificial intelligence is coming up to ease our practice more than a 3D or a 4D rendering to complement us with a more precise measurement, even for a very poor views. Any FMF certified sonographer has made this kind of measurements so that in varied views, like from a good view, suboptimal or poor views, we can do this with a one click of button. So it is very easy and practically applicable, and it is easy to use with our very routine and very busy practice. This is very easy way of taking any measurements if we need. So with this, I say thanks for the opportunity. Thank you.
Yeah, thank you, Navya. It is a beautiful, elaborate presentation.
Thank you, ma'am.
I think we have to have a...
Wonderful. Very nice.
Thank you, ma'am. I try to concise because, as we know, it's a very, very vast and big topic, actually. What is the view we can talk about? It is like kind of very vague. So I try to concise. Hope I justified my topic.
Yes.
Nicely done, Navya.
Thank you,
Madam,
ma'am.
welcome, madam.
Good evening.
Thank you. Good evening. Good evening. Good evening.
Thank you. Shall we go on to the next talk? Chairpersons?
Yes, ma'am. Yeah. So the next topic is...
Next. Dr. Lakshmi Ravi. Dr. Lakshmi, the next talk.
Dr. Lakshmi Selvan.
Yes.
So if we have any...
The next topic is a pragmatic approach to facial clip by Dr. Lakshmi Selvaraj ma'am. And I invite Dr. Vaidyanathan. Hello.
Yes, ma'am.
Dr. Antilakshi here.
Yes, ma'am.
I was listening to the lecture of Navya. Okay.
Yes,
Is
ma'am.
it meant for the obstetrician or the radiologist?
For the fetal medicine.
Such a detail.
It's more for the fetal medicine people. But these are the things which we look for.
Some salient features that alone can help the obstetricians. Okay, but remembering all these details, I think it will be very difficult. It is too in detail. Malati, it is for you.
Yes, madam. Madam, the angles will be done by us. and we will only say why it is called as micrognathos. So the documentation will be based on the angles.
Okay.
So this is the
So-
homework we do behind every diagnosis we make, ma'am. So
Okay.
this is all the
Okay.
homework, and only the precise diagnosis we will write another report, ma'am. Definitely.
Okay. Okay.
You don't
I
have to
was
worry
not
much
just
about the angles.
too much of details, I thought. Okay, ma'am. Thank you. Thank you. Thank you.
Thank you.
Okay, ma'am.
Thank you, ma'am.
Thank you.
I'm very
Sorry,
happy to introduce our next speaker, Dr. Lakshmi Selvaraj. She's the director of Sri Lakshmi Clinic and Scan Center, Trichy, Tamil Nadu. She's one of the leading pioneers in implantation of prenatal in setup in rural setup. She's a gold medalist and best outgoing student at Government Kumaramangam Medical University, Salem, Tamil Nadu. She has lots of papers and presentations presentations and conferences. She's a teaching faculty, invited national faculty for 3D ultrasound, obstetrics and gynecology, faculty at Ian Donald University, School of Ultrasound in Tirunelveli. Publication, she has published she's published many papers, and she's a reviewer of journals. Over to you, madam.
Thank you for those nice words, and thank you for this opportunity. I'll just share my screen, and please let me know if you are able to see my presentation. Yes, the slide is visible.
Yes, madam.
Okay. So it was an exhaustive lecture by Navya. Congratulations. You had told a lot about the views and faces. What I'll do now in my lecture would be, I'll just take you across a very practical approach to facial clefts, and I'll restrict this talk to identifying basic tips and tricks to identify facial cleft. So before going into the details of how to assess a facial cleft, we all need to know the basic guidelines. What is a minimal requirement in a routine anomaly scan? That's what our guideline tells. And the guideline says that the basic examination of the face should include visualization of the upper lip, assessment of the presence and position of the orbit's eyes, and if possible, assessment of the fetal profile. This minimum guidelines just tells us what has to be mandatorily be done at the time of evaluating the fetal face. And these are the three basic views what we all do. That is the mid-sagittal profile, this is the axial view of the orbits, and this is the nose chin view. Now, these three views are what we do, the basic views when we do the fetal face. And how do we now use these views to assess facial clefts? That's how we are going to take you across. To make life very simple for you, I just have 10 points to make you understand. And I believe that these basic tips and tricks will help all of us to understand what are we dealing with. So the one golden view which is there for assessing cleft lip will be the nose chin view. And all these sort of anterior clefts, all these, this is one unilateral, this is a bilateral, this is a complete unilateral, complete bilateral. So all these types of anterior clefts can be easily assessed by this nose chin view. And the only one type of cleft which we will miss out is an isolated cleft of the posterior palate, because in the nose chin view, it will only let you know whether there is a cleft in the lip, but it does not evaluate posterior portion of the palate. But the guidelines actually tells us that you need to identify cleft lip, and the palate is not a part of a routine guideline. That's something basic what we need to understand. So we can extend our views. So how to optimally do your nose chin view? That's more important. Basic the tips and tricks. So when you do a nose chin view, just look at this. As C, the C, which what is labeled as C, is the most optimal view of how to look at the nose chin view. And I've shown in this video of how we get this nose chin view with lots of amniotic fluid, and how from the basic BPD plane I'm going down and then getting to this nose chin view. Now, whenever we do this nose chin view, if you see something bright like this, that means you've gone deeper down to the alveolar ridge and you have not imaged the lip at all. And this view we might miss out on a cleft lip. And the vermilion border of the lip should be seen well. And I let you know why is where there should be some fluid between the upper lip and the lower lip. So this is how we need to visualize the nose chin view. And of the most, cord loops, fetal hands, or the placental surface, all those things should be avoided when we are trying to look at the nose chin view. Now, you look at this nose chin view and see if there is, just think if there is a cleft lip or not. I'm just going to show you the sections. When I go more anteriorly, I'm able to see this clefting here. And you see that when there is enough fluid, it will delineate the vermilion border nicely. And you can see the subtle clefting in the lip nicely brought out. So very simple trick is do the nose chin view in a proper way with sufficient amniotic fluid and little fluid delineating the upper lip and the lower lip separate. Now, pattern recognition. We do a nose chin view, and there are certain specific features for each type of cleft. How do we understand that pattern? What happens in a unilateral cleft lip will be there will be a lateralized defect in the upper lip, and the upper lip would be divided into two components. And the most important feature of a unilateral cleft lip would be the asymmetry of the nostrils. See, look at this. This is the alae nasi. This is one nostril, and look at the other nostril. It looks as though the nose has fallen down into this pit. So this is a very characteristic feature of the unilateral cleft lip. This is pattern recognition. What happens in a bilateral cleft lip? The soft tissue of the upper lip will be partitioned into three components. And this excess soft tissue mucosa under the nostrils, this is the median process. This median process is what that appears in the mid-sagittal section as a premaxillary protrusion. And you always have two clefts on either side of the median process. This is how a bilateral cleft lip would look like. What's a median cleft lip? A median cleft lip is a midline defect in the soft tissue mass of the upper lip, and there is absence of the median process with non-visualization of the philtrum. And it is very important to recognize a median cleft lip because we all know that this type of a median cleft lip and palate is that one which is most associated with syndromes, especially the holoprosencephaly types. Now, can we misinterpret clefting? Can we misinterpret a unilateral cleft as something else? So if you look at this image, it looks like a unilateral cleft lip, but if you properly image the nose chin view, what happens? There are two paramedian defects, and you see the median process here, and you understand that this is a bilateral cleft lip and palate. And the error, what we did here was, look at this. This is the placenta, and that is why I earlier said you should visualize the entire nose chin view and both the lateral angles of the mouth. Then the identification of the cleft and the type of clefting will be right. Now, you see that it looks like there are two cleft paramedian defects here, and hence is this a bilateral cleft lip? I'll throw your attention to this video and then you just see what's happening. You see that there is a centralized defect here and that median process is actually missing. We said in a bilateral cleft lip and palate, you will have presence of the median process. Whereas look, there is absence of the philtrum. And what you see here is nothing but a median cleft lip. And again, this identification of this type of cleft lip and looking for its associations are very, very important when we look at a simple nose chin view. This nose chin view is the key view and that has to be done appropriately. So you clearly look in this video, you will visualize that the median process, what is called the philtrum of the upper lip is missing. And whenever the philtrum is missing, then the diagnosis would be median cleft lip and not a bilateral one. And to reiterate the findings, This asymmetry of the nostrils and stretching of the alae nasae is a very typical feature of a unilateral cleft lip palate. So with this, I'll take you to the associations. So look at this. There is a cup-shaped monoventricle, and you know this is holoprosencephaly. And you see there is absence of the median process or the philtrum. And you know that there is a median cleft lip. There is also a depressed nasal bridge. And you see there is complete absence of the maxillary line. So a very severe facial abnormality along with holoprosencephaly. The first clue will be from this nose-chin view, where you can identify the median cleft lip. Next, when you do the mid-sagittal section of the face, of course, we understood all the angles and how to do it. But basically, when we just have a look at the fetal face, the subjective assessment of the fetal face, mid-sagittal profile, what are the important things one should look at? The first thing what you would look is this upper lip. Look at this. This is the philtrum. And this area is very, very important when we look at the mid-sagittal profile. And the second point of importance is the collinear relationship of the nasal bone, maxilla, and the mandible. Just look at this. I draw a line, and you see that this the tip of the nasal bone, the maxilla, and the mandible will all touch this line. And this is a very easy and a very simple way to assess for micrognathia, retrognathia, or for the presence of a premaxillary protrusion. So the relative positions of the maxilla and the mandible needs to be assessed, and that can be done with a simple line like this. And whenever you're thinking of facial clefts, this tongue position, when you do the mid-sagittal profile, we all see that the tongue actually touches the mandibular, you see this is the alveolar ridge of the mandible, and you see the tongue comes out and goes inside, and this is the normal position of the fetal tongue. And this is very, very important when we are speaking about facial clefts, and I will tell you the importance in the subsequent slides. Now, look at that. So, very simple steps. If you draw a line and see the position of the maxilla and the mandible, you will understand that the maxilla is protruding out. So this is premaxillary protrusion, and this will happen in a bilateral cleft lip and palate. Whereas, look at this mid-sagittal profile. The upper lip is actually missing here. And if you draw a line, you will see that the line, which is the maxillary line, is receding backwards. And this is the mandible, and hence this is a feature of a median cleft lip and palate. So just a simple line will tell you that you are going to be dealing with a problem or not. Now, we have finished the nose-chin view, and we'll move little posteriorly. Now, whenever you do the facial profile, and whenever you think about whether either the cleft has extended into the secondary palate, or you're worried if there is a previous child with a cleft palate, you want to assess for a cleft of the secondary palate. Though assessment of the palate is not a part of the guideline, if you do not identify cleft palate, it's okay, it's acceptable, because the guideline does not ask you to do so. But if you try and do an extended imaging to look at the cleft, to evaluate the secondary palate, this is our problem. So the question is there a cleft of the secondary palate? Many or most often, we would be misled thinking that, okay, this is very dark here, and maybe the maxillary line is not continuing. But the fact is that this premaxilla is actually casting a shadow, and what you're seeing is only a shadow, and this shadow of the premaxilla should not be misinterpreted as a cleft of the secondary palate. Then how do we do? How do we identify a cleft of the secondary palate? Now the problem, nose-chin view is very easy. You can identify all types of cleft lips, but the problem with the cleft palate is, you see, the palate is a dome-shaped structure. You see, it's like a dome. And if you cut the palate in any angle or with any particular plane, you cannot see the entire dome-shaped structure. And that is why a cleft of the secondary palate is very, very difficult to identify. So this is actually the premaxillary portion. This is the bony secondary palate. This is a soft palate. This will be the ula. And this is actually the voma. This is the relationship of the vomer with the palate. What happens is, in your routine mid-sagittal profile, you can see the premaxilla, you're very happy with it. You can see the tongue position. You know you have seen the upper lip. But what happens behind this? Behind this, there is so much of shadowing that you really don't know what's happening to the secondary palate at this point. So, we came out with the sign which is called as a superimposed line sign, where the cranial line will be the vomer and the caudal line will be the secondary palate. And in early mid-trimester or in late first trimester, whenever you look at the maxillary line, the posterior aspect of the maxillary line will be bifid. This will be the vomer and this will be the secondary palate. So if you see two lines, then you know, okay, there are two lines. That means the secondary palate is present. If you see only one line, then maybe the secondary palate is absent and hence you have to go and do extended imaging. So this maxillary line is actually formed by three components. What are the three components? One is the premaxillary portion. The second is the secondary palate. The third is the vomer. This we need to understand whenever we are dealing with the cleft. And what will be the tips to evaluate secondary palate? First thing is fetal position. Do not try and evaluate the secondary palate when the fetus is in a neutral position. Always go for the fetal neck in a slight extension. And the angle of insonation is important. See the angle, the ultrasound beam is insonated at an angle to see the entire palate. See, now you have avoided shadowing from the premaxilla. You can see the premaxilla now, bony secondary palate and the uvula. If you have fluid in the oral cavity, then that's magic. Because if you have fluid in the oral cavity, that will clearly delineate the entire palate for you. And you can not only see the premaxilla, you can also see the secondary palate. This is the soft palate, and the soft palate ends in this equal sign, which is nothing but the uvula, which was already spoken by Navya. Now, why did researchers started looking into the uvula was because the secondary palate itself was very, very difficult to visualize because of the shadowing, and hence all clefts of the posterior palate, isolated cleft palate, will always start from the midline, from the uvula. So if they believe that if you can see the uvula, then that is an intact, as a surrogate marker for the intactness of the secondary palate. And that's why we are looking at the uvula. The uvula can be seen in the axial section, just if you go caudal from your BPD plane. But to see this equal sign, something is very, very important. And what is important is fluid in the oropharynx. Only if you have fluid in the oropharynx, you will be able to see this equal sign, which is the uvula. The pitfall in looking for the uvula in the transverse view or in the axial view is that the glottic folds or the vocal folds, this will mimic the uvula, and hence it is better. Whenever we are trying to look at the uvula in the axial sections, we can also look in the coronal sections and see, say, look, this is a coronal section where you can see the glottic folds here. You can see the uvula both in the same plane and in the same section. And now you are very sure that you have not mistaken one for the other. So this is how one sees, this is the uvula and this is the glottic folds. So this is how you can look for the uvula in the different planes. And the real-time swallowing fluid dynamics. Whenever the baby tries to swallow fluid, so when the baby tries to swallow fluid, you can see the mechanical movement of the soft palate and the uvula. And you see this is oral cavity, this is tongue, this is the nasal cavity, this is the normal palate. But look at this case. This is the tongue, this is the oral cavity, this is the nasal septum. You do not have the secondary palate here. It's a complete cleft of the secondary palate, and you see that the nasal cavity is communicating with the oral cavity. And so much of clarity you can get, but you have to wait for the fetal position and you have to wait for the swallowing movement of the fetus. Then you will be able to identify this. Now, I'm going to ask you another question from this image. Is this a cleft of the secondary palate? Now, if you take a closer look at this image, you will understand. This is the premaxilla. There is nothing extending lower down. What you see here is only fluid. And you see a small bony structure. You don't see the muscular curtain. You don't see the uvula. And this small midline structure is the vomer and not the palate. And hence, this is a cleft of the secondary palate, whereas the previous image was only shadowing. So, of all the views and angles, what Navya told earlier, there are certain views which are very, very crucial for the analysis of a cleft extension into the palate. And we will see what are those crucial views. One is the anterior alveolar ridge of the axilla, where you can see the tooth buds. And the next is the next view is the bony posterior edge of the palate. This is the bony posterior edge of the palate, and these are the pterygoid processes. This is to look at the posterior part. You cannot see the entire palate in the mid trimester because of the dome shaped structure. And under normal circumstances, you will have a dark area here, and this dark area is not yet cleft. It's only the dome. And then you have to demonstrate the interruption in this bony posterior edge. And the third view of importance is the premaxillary triangle. Here, you cut the palate here and you will identify whether the cleft has extended into the primary palate and the secondary palate. And the last view is the mid-sagittal profile. And I told you the importance of the mid-sagittal profile when you're looking at facial clefts. Look at this. This is normal. And when you have a cleft, see, whenever you say there is a cleft lip, then the next question, during counseling, when the fetal medicine consultant or the primary OBGYN, everybody sits together. And when you want a referral to the maxillofacial surgeon prenatally, they'll ask you, is it an isolated cleft lip or it has extended to the palate? So how do we assess cleft extension into the palate? So for that, this view, as I told you, is a crucial view. It will let you know whether the cleft has extended through and through inside. And you see that the bony posterior edge also is gone off. So you know that this is a complete cleft. And that is how you will identify cleft extension into the palate. And this is the importance of the bony posterior edge of the palate and how to get at this view. So it's a simple posterior plane. See, this is the mid-sagittal profile. And you see, you have to insunate the beam like this and you have to stop. You have to go posterior to the nose chin view, and nose chin view is a coronal section. So in the axial section, you have to go posterior to the alveolar ridge. And here you will get the bony posterior edge of the palate. And whenever you see an intact line, you know that the secondary palate is intact. Now, this is 3D applications. You could use an OmniView technique and show the entire bony length of the palate. This is normal. This is bilateral cleft lip and palate. But under routine circumstances with 2D, it is very, very difficult to assess cleft extension into the palate because of the shadowing. So now when you see this image, you're all very sure that this is a unilateral cleft lip and palate because it has all the characteristics of a unilateral cleft lip. The upper lip is divided into two. There is a lateralized defect. There is a nasal asymmetry. Even if you do the 3D rendering, it will clearly tell you, yes, there is a unilateral cleft lip. But how do we assess whether it has extended to the palate? So the clue is additional views. Look at this. It's gone inside the alveolar ridge. So it's a labio-alveolar palatal cleft. Look at this. The premaxillary triangle base is gone. And you also see that there is complete absence of the maxillary line. So I'm going to say this is going to be a complete unilateral cleft lip and palate. So that's important. So you see, this is a cleft lip here. And you see, there is an interruption here. Okay, you know that this is a labio-alveolar cleft. But look at the premaxillary triangle. This is very much intact. That means the entire secondary palate is going to be intact in this case. And counseling for a complete unilateral cleft lip and palate and for a simple cleft involving the premaxilla alone will be a lot different when the maxillofacial surgeon says about the surgery and the time required. Hence, it's important that we identify by imaging what is the true extent of the cleft, and these can be done with simple basic views. And this an intact premaxillary triangle proves that the anterior cleft has not extended to the secondary palate, because if this cleft has extended, what will happen? There will be a disruption here, but you're not seeing the disruption here. So we can use these simple planes and identify whether the cleft extension or not. So look at this. You know this is a bilateral cleft lip, but look at what happens at the alveolar ridge. You see, there is an extension here. Rendering shows you that there is a bilateral cleft lip, but you have complete absence of the premaxillary triangle. And you see that there is complete absence of the secondary palate here. And hence you can say that this is going to be a complete bilateral cleft lip and palate. And of course, you have this 3D multiplanar additional imaging where you can show at a stretch how the cleft has, on both sides, there is a cleft and how it has extended into the midline. So this is all additional imaging points, but this will help us to try and define what is really the true extent of the problem. So this is a simple algorithm, what we have published in our book to help us use the crucial views and simply try to arrive to make your diagnosis more appropriate and which will help in prenatal counseling. A very important, though it's a rare entity, it's an important condition to be discussed, because what happens in a Peary-Robin sequence is there is retrognathia, and there is a small posterior cleft of the palate. And if you can remember in Navya's slides, she showed a V-shaped mandible, but here the mandible will be U-shaped and it will be in the shape of a boomerang. And you see the receding chin. This chin is very much receding from the maxilla, and you know that this baby is having retrognathia. Is all that enough? Why all this is not enough is because you have identified. See, now if you see the normally you must see the bony posterior edge like that, but actually there is a small clefting here. But this is not the real concern. The real concern is the tongue, because what happens in a Peary-Robin sequence is the tongue is actually vertically positioned and it falls back and closes the airway. So the baby in the immediate postnatal period will not be able to take its first breath and it will have a respiratory distress. So whenever there is glossoptosis, you look at the position of the tongue in retrognathia. See, this tongue is now falling backwards, and you see that the tongue is actually failing to reach the anterior alveolar ridge of the mandible. And you see the tongue sitting here, vertically positioned. It is not horizontally positioned, it is vertically positioned. And whenever the tongue falls back, and if you are not prepared for it, the NICU will be a disaster. If the baby is not delivered in a NICU, then it will be a disaster, because you need a multidisciplinary team along with you to deliver these sort of babies. And that is why the identification of a Peary-Robin sequence in utero is very, very useful in terms of counseling, and also to prepare your NICU team before delivery. So you can clearly see that this tongue, when the baby is trying to swallow, there is retrognathia, but this tongue can never come out because there is glossoptosis. And this feature of glossoptosis has been reported in literature and in ultrasound as early as in 2005. So whenever there is retrognathia, it's mandatory that the fetal medicine team or the imaging team just sees if there is glossoptosis, or at least cautions the OBGYN that there can be a possibility of a Peary-Robin sequence and the baby needs to be delivered in a NICU setup. There is a very good sign to tell you that. And what's that sign is, just look at the coronal section in this. What you're supposed to see is, this is actually the glottis, and here you should see the uvula. But instead of the uvula, you see a soft tissue which is coming and going, and that soft tissue is actually the tongue. It is falling back and closing the pharynx for you every time the baby is trying to swallow. And that is a very good sign, and that's called as a tongue-filled pharynx sign. So it is mandatory. Let's see the cleft, the posterior cleft which we have, this is the normal This is a cleft, posterior cleft. It's very, very small. That's not important. Whenever there is retrognathia, if you feel the tongue is not coming forward, then the suspicion of glossoptosis needs to be raised and written in our documents. For example, the last task is, this is also a case with retrognathia. You see, this is the maxilla, this is the mandible, the chin is receding backwards, and this is also a case of retrognathia, but which has glossoptosis. You look at the tongue position. The tongue tip is here, okay? So this is the tongue tip. The tip of the tongue is reaching the anterior alveolar ridge of the mandible. So I know that this is not a case of glossoptosis. So my terms will be, okay, this is only retrognathia and we'll follow this as retrognathia. Whereas in this case, this is retrognathia, the tongue is backwards. That is why you're having amniotic fluid here. The tongue can never reach outside. So this is retrognathia with glossoptosis, and we will raise the caution. So it's important that whenever we think of a cleft lip, we have to search, do a mandatory search to look for other associations, because that is more important. Whenever there is micrognathia, then you have to think of syndromal associations for a pure Robin triad, ear abnormalities, then trichocolins, golden hair garlands, orbital abnormalities, and nasal abnormalities. Then you can have a holoprosencephaly type of disorders. And what are the extrafacial abnormalities? You can have a cleft lip and palate with a holoprosencephaly Dandy Walker spectrum, the velocardiofacial syndrome, or the 22q11 deletion, the Dijot syndrome. And if you have skeletal system abnormalities, then you can have any of these syndromes. The list is very, very huge. I just brought a very few to just give you you an exposure that whenever there is a cleft lip and palate, the primary thing is first identify the type and extent of cleft. Second, is it truly isolated or is it associated with syndromes? So to summarize, the simple basic points: an intact nose chin view rules out an anterior cleft of the palate. An unremarkable uvula implies the presence of an intact secondary palate. That's why we go and look at the uvula. And if you see the uvula, okay, fine, we think that the secondary palate may be intact. An intact premaxillary triangle proves that the anterior cleft has not extended into the secondary palate. An intact posterior edge of the palate rules out a cleft of the bony secondary palate. And whenever you have retrognathia, make an attempt to look for glossoptosis. Simple key points which will help assessment of facial clefts in the antenatal period easier. And so we know what we have to basically do as a part of the guideline. All these key points may take you one step above the guidelines and might help you to have a proper assessment of facial clefts. We have an entire book dedicated to evaluation of facial clefts, and you would find it very useful because that book has 7 chapters for first trimester, and the remaining 6 chapters are for the mid trimester and for the counseling options in facial clefts. Thank you so much for your patient listening.
Thank you, ma'am. Thank you for a wonderful talk. It was a very detailed one.
Thank you very much, Dr. Lakshmi. I think wonderful as usual. Lot of elaboration, lot of imaging. Thank you very much. I think Dr. Mani has joined. Welcome, Dr. Manikandan.
Thank you, madam. Lovely to see all of you. Thank you, Lakshmi, madam. Brilliant.
Lakshmi, it is a beautiful talk. It shows your
You've
passion,
done
no?
so much of
Passion.
research on that. It's an extensive research. So
Really, I enjoyed your talk.
Thank you,
Yeah, we
ma'am.
are-
Thank you.
we are
I
very
will go and
pleased
see
to have
all
you
the
in our-
tasks tomorrow. Very nice.
We're extremely privileged to have you here. Thank you very much for
Thank you.
joining. Thank you. Next talk with Dr. Ravi.
Next topic is interesting cases in fetal imaging by Dr. Revati Chandrasekharan, our dear Revati from Trichy, consultant fetal medicine center and Sprout Fetal Medicine Center, district rank holder in secondary school, MBBS from Kanyakumari Government Medical College, MS from Trivandrum Medical College, fellowship in fetal medicine. She won gold medalist in fellowship and paper on the mental health and antenatal women on non-government era. Publications in many journals, and area of interest is fetal therapy. Over to Revati, please.
Thank you, madam. Thank you for the kind introduction. So I'm very happy to join this session because it is our 5th session in our Tea and Fog webinar series on facial imaging. And from the bottom of my heart, I want to thank Dr. Malati madam for this beautiful and precious opportunity that she keeps showering on me all the time. And I would like to thank Dr. Sampath madam and Dr. Revati madam, Dr. Radhika madam, Dr. Tamil madam, everybody for encouraging us in our society. So my topic today is on interesting cases on facial imaging. So this is moreover like a rapid fire look into all the antenatally detectable facial anomalies rather than concentrating on a single anomalies, because my aim on this session is to give an insight to all antenatally detectable facial anomalies and to have a familiarity with the anomalies and what can be done with the anomaly and how to counsel the patient and how to know whether it is a lethal anomaly or a non-lethal anomaly, which anomaly you have to approach a fetal medicine specialist. So that will be my aim in on today's talk. Just a moment. So as I told earlier, the aim of the session is not to dive deep into the ocean and look for all the precious pearls. But then I just want to, sit on the shore and have a chill talk about the facial anomalies and a brief note on every anomaly. So when you take a facial anomaly, whenever we see a report which says some facial anomaly is there, first we have to know what is the condition, and we should know first and foremost we must know whether it is a lethal anomaly or a non-lethal anomaly. Then we will go back and see whether what could be the etiology, whether this etiology will need a prenatal testing or not, and how to plan the delivery of the baby, and what should be the intrapartum management of the baby, and what should be the postnatal treatment available that has to be discussed with the patient and the couple, and whether this anomaly, whether if it is a lethal anomaly, will recur or not. So face is a very big structure. It is not a very small structure. It is a very important structure in any human body. So it has got lots of parts, and we'll start from top to bottom. So we'll start with the forehead. So in forehead, we'll have first anomaly I'll be discussing is frontal bossing. So whenever somebody reports you frontal bossing, you should know that it is nothing but an excessive protrusion in the frontal bone. Whether it is lethal or not, no, non-lethal if it is isolated. What could be the cause for these frontal bossing? It could be due to any drugs that you have taken during the pregnancy, basal cell nevus syndrome, congenital syphilis, and other skeletal dysplasia, Fragile X syndrome, rickets, and certain type of anemia such as thalassemia major. So since it is associated with thalassemia major, that is the beta thalassemia, you should always go back and see whether the parents are affected with thalassemia or not, or take the history whether they are having anemia or anything that is related to thalassemia. So whether this condition needs a prenatal testing, if at all, after finishing the scan, you think there are other associated anomalies and it is fitting into some syndromes per se, then you have to counsel the patient in detail that it looks like this syndrome and you will be needing a prenatal testing to rule out if this syndrome is there or not. And antenatal period usually pertaining to frontal bossing will be uneventful if it is syndromic, and it will be sticking to that. Delivery as per the obstetric indication and treatment option available will be usually conservative. Pertaining to frontal bossing, we don't need any certain treatment if it is isolated. Then we have the slanting or the sloping forehead. Slanting or sloping forehead indicates microcephaly. So lethality, whether it is lethal, it is non-lethal if it is isolated microcephaly, but it is lethal if it is associated with any genetic, infectious or environmental exposures. Prenatal testing if it is needed, as I said earlier, if at all after finishing the scan, if this slanting forehead is fitting into any kind of syndrome, then it will be needing a fetal DNA testing, and treatment will be usually conservative. The long-term prognosis and recurrent risk of microcephaly is usually related to its underlying cause. Then we have this thing called proboscis. Proboscis is nothing but a cylindrical protuberance in the fetal forehead. It is usually associated with cyclopia. Cyclopia is nothing but single or fused eye in the fetus, or ethmocephaly. Ethmocephaly is a condition where the eyes will be so close to each other. It is called hypotaylorism, and a single nostril. So whether it is lethal, yes, it is lethal, because this condition is invariably associated with holoprosencephaly, which is a condition in which the brain fails to cleave. So you will have a single brain. So the cause will be in 40% of the time, this proboscis will be associated with trisomy 30, and maternal diabetes will increase 200-fold the risk of proboscis. So prenatal testing, if it is required, yes, it is required, because it has got high association with trisomy 30 and also many other syndromes. Antenatally, it will be usually uneventful. Usually this condition is lethal, so we will not advise the patient to continue the pregnancy. And if at all it reaches term, the delivery option will be as per the obstetric indication, and the treatment increase out in a orbital margin. So if it is isolated, no, it's not. The any brain defect as well as multiple syndromes. So prenatal testing, if it is needed, yes, karyotyping and FISH analysis for 22q deletion, and DNA analysis if syndromic. Antenatally, usually it will be uneventful delivery as per the obstetric indication. Treatment option, if it is isolated, not fitting into any syndromic condition, the baby is having only isolated hypertelorism, or the option of plastic surgery can be considered, but I don't know how successful it will be and how familiarly everybody will do it. Hypotelorism, opposite to hypertelorism. So you will have a decreased distance between the medial aspect of the orbital walls. Lethality ratio, when it comes to hypotelorism, it is usually lethal because it has got strong association with brain anomalies, especially holoprosencephaly. So it has got high association with trisomy 13, as I discussed earlier, with proboscis, and also it is associated with many genetic infections and environmental exposure. So prenatal testing, yes, it's invariably needed for this condition. And treatment option, if it continues, if the baby got delivered, then usually conservative, and if at all the parents are willing for a plastic surgery or something, we have to have a proper counseling regarding that. And we have other condition called anophthalmia and microphthalmia. Both anophthalmia and microphthalmia can be either unilateral or bilateral. Anophthalmia is the condition where there is a complete absence of eyeball, and microphthalmia is a condition where the eyeball is smaller than as it has to be for that particular period of gestation. The lethality, it is usually lethal because it lethal for the visual acuity of the baby, and because it is strongly associated with chromosomal abnormality and single gene disorder. So this baby will definitely need a karyotyping, and if bilateral, DNA testing for Soxter mutation is needed. Delivery as per the obstetric indication. If they continue till the term and they get delivered and they need some mode of intervention, yes, there are interventions to save the baby, like tissue expanders, orbital implants, and orbital reconstruction, but the visual acuity will never be retained. And we have other interesting condition called dacrocystocele. So congenitally, there will be dacrocystocele, which can be seen in adult life also. So this is usually occurs because of delayed canalization of the lacrimal duct beyond 32 weeks of gestation. Usually it will be unilateral. Sometimes it will be bilateral also, as seen in this image. Lethality, usually it is non-lethal. Cause will be usually median facial or brain defect. Prenatal testing is not required. Antenatal will be uneventful. Delivery as per the obstetric indication. Treatment option, you have to do nasolacrimal duct probing. Usually it is conservative. If the baby is not improving, then nasolacrimal duct probing can be done. If it persists only beyond 6 months of life, till 6 months of life, it is only conservative. So this is a very interesting case that we have seen in our center, Trichy Fetal Medicine Center. So this is a case which presented with an orbital mass. One eye was clearly seen, the other eye we were not able to see. So we have given a diagnosis of orbital mass, possibly a teratoma. So this is the congenital orbital teratoma. You can see the postnatal image of the baby, how the eye is protruding with a big mass from the eye. It is usually sporadic, and detailed counseling soon after the diagnosis is needed, because this baby is going to have an extensive surgery and vision of one eye is definitely lost. And because of the posterior retinal detachment and everything. C-section is preferred with caution for this baby, because there is a mass which can be disturbed during the normal delivery. And treatment option, usually ophthalmological intervention after birth may be needed. Complete excision of the mass will be needed, and loss of vision is expected. Aphakia is a condition where there will be total aplasia of the anterior segment of the eye. So this nothing but absence of lens, that's all. So it will be primary or secondary. Primary is like it didn't develop only. Secondary, it has developed, but it has reabsorbed or expelled during the injury. So 75% it will be unilateral and 25% it will be bilateral. It is lethal because the baby is not going to have a vision. The cause is due to multiple gene mutation and torch infection, very important. So prenatal testing, while counseling, you have to tell there could be a genetic etiology and it could be due to infection. So elicit the history properly and advise them to go for torch PCR. Antenatal, it will be uneventful delivery as per the obstetric indication, and treatment option will be intraocular lens placement after birth of the baby, not soon after the birth of the baby, but it will take some time because growth of the eyeball is exponential during the early ages. Congenital cataract is a condition. Just like the adult cataract, we'll have something called congenital cataract, which can be picked in the antenatal period. So it could be either unilateral or bilateral. It is nothing but opacity of the lens. So the visual acuity of the baby is going to be definitely affected. If it is bilateral, it is usually associated with syndromes. Unilateral condition will be usually associated with fetal infection. Whether it is lethal, it is lethal for the visual acuity of the baby, not the overall lethality of the baby. Cause will be sometimes it is associated with syndromes like Walker-Warburg and so many other syndromes. Usually rubella will be associated, toxoplasma and CM will be associated in 30% of the cases. So while counseling the patient, you tell them that there is a condition which will cause a loss in visual acuity, and they have to go to prenatal testing where they have to do the KT, CMA and torch PCR. Obstetric indication, delivery and treatment will be ophthalmological intervention soon after the birth of the baby. Will usually give a good result because this congenital cataract can be easily treated with an IOL. So this is a very interesting case that we have seen, eversion of the eyelid, which can be seen antenatally. So the upper eyelid is averted with the protrusion of the edematous palpebral conjunctiva. So it will need a proper ophthalmological evaluation soon after the birth of the baby. The problem with this baby is the conjunctiva is continuously, and conjunctiva and the cornea is continuously exposed to the amniotic fluid. So there will be some amount of affection to the cornea conjunctiva. So soon after the birth of the baby, proper ophthalmological evaluation is needed, and topical lubricant has to be put to prevent desiccation of the exposed conjunctiva. So now we have finished the forehead and beautiful eyes. Now we will move on to the ears. Ears, we can see low set ears. Low set ears are nothing but they are just a clinical feature in which the ears are just positioned lower than the head than usual. Lethality, it is non-lethal if it is associated, but it is associated with Down, Turner, Noonan, and so many other lethal syndromes. If it is associated with these lethal syndromes, then it becomes lethal. Prenatal testing, if it is fitting into any syndromic condition, then you have to counsel the patient and ask them to go for an invasive testing. Antenatally, it is unequal and delivery will be as per the obstetric indication. Treatment option, it is usually cosmetic if at all the patient requests a surgery. Microtia is a condition in which the external layer is malformed or underdeveloped, and it is usually associated with oral atresia. If it is associated with oral atresia, then there will definitely be conductive hearing loss will be there. So lethality, if it is associated, not associated with any syndrome, and if it is isolated, then it is non-lethal. Antenatally, it will be uneventful. It is associated with umpty number of syndromic conditions. So whenever you see a microtia, go back, see your scan completely, and look for any other findings which fits into any of these syndromic things. If it is fitting into any syndromic thing, it is always better to have a prenatal testing, and the recurrence risk is usually based upon the etiology. Delivery will be as usual. Treatment option, if it is isolated and if the baby is expected to survive well without any syndromes, then prosthetic ear placement can be tried with a high density porous polyethylene implant. Preolicular tag, very rarely seen, but it is a very common isolated congenital anomaly. So it can be either lobulated or pedungulated, which is located anterior to the external ear, unilateral, bilateral, single, multiple, anything it can be. Lethality, if it is isolated, it is not at all lethal, but it has got a high association with trisomy 13, 18, and other syndromes as I have mentioned here. And this preolicular tag is found to be associated with many renal conditions like renal agenesis, kidneys, and so on. So whenever we see a ear tag in the scan, we have to always go back and see whether the kidneys are fine. So prenatal testing, if it is syndromic, kindly go ahead with it. Antenatally, usually uneventful. Treatment option, usually cosmetic surgery if required. See, the excision of the tag and making the baby all beautiful and everything. So ear is done. Now we'll move on to the beautiful mid face. So mid face, binder faces. Binder faces, previously it was beautifully spoken by madam. So it is nothing but flat nose and underdeveloped jaw. So the midfacial hypoplasia with a protruding lower jaw will be there. If isolated, it is non-eventful, but it has got high association with many syndromes, especially this chondrodysplasia punctata and skeletal dysplasia. It usually occurs because of alcohol and vitamin K deficiency, phenytoin and warfarin. So when your patient is taking any of these drugs, always send this patient to a proper fetal medicine specialist, so that because it is always associated with binder facies. So prenatal testing is required, counsel the patient properly. And if the baby reaches the term and it gets delivered, is there an option? If the patient is asking you, just tell them there is an option. You can have orthodontic care, Leafort 1 or 2 osteotomy, well known by all pediatric surgeons, after 15 to 16 years, because 15 to 16 years, the baby has to grow and mature. Absent nasal bone, we are very familiar with absent nasal bone because we see at least one case of absent nasal bone in our day-to-day practice. So it is a very specific ultrasonographic marker. It can be physiological variation, and it will cause no aesthetic issues to the baby. It has got high positive likelihood ratio for chromosomal aberration. Whenever you see absent nasal bone, counsel the patient for an invasive testing with the patient CMA. Usually antenatally uneventful. Treatment option, it doesn't need any treatment. So mid faces is done. Now we have to go to the lips and palate, which I'm right royally skipping because madam has beautifully spoken about all the abnormalities of the lips and palate. So now we will move on to the mandible. So mandible, we will know there is micrognathia and agnathia. Micrognathia is nothing but a small chin. Agnathia is no chin. So facial malformation characterized by mandibular hyperplasia and small receding chin that fails to maintain the tongue in forward position. If it is isolated, it is non-lethal, but then it has got high morbidity postnatally. Antenatally, the patient will have polyhydramnias. Genetic etiology, high association with many syndromes, including Pierre-Robin, Tickler, Treacher-Collin, and Niger syndrome. Prenatally, definitely these patients has to be counseled for invasive testing to look for any other syndromic association. And usually the recurrence risk is based upon what is the etiology. C-section is needed because many airway problems are potential for neonatal airway problems. So C-section and proper exit and procedure may be needed. So it is always better to counsel for the worst. And treatment option, partial glossectomy and secure the airway. Prognathia is a condition where there will be prominence of the chin will be seen. It could be either mandibular, maxillary, or bimaxillary prognathism. It is non-lethal if it is isolated. It will cause malocclusion, malalignment of the teeth, bruxism, speech difficulty, and TMJ disorders in the future. Usually, it will be caused because of acromegaly, Cruzon syndrome, very particular, then basal nevus syndrome, and trisomy 21 also. This baby is usually present with polyhydramnias, and AFP will be elevated in these babies. They will be needing invasive testing, and corrective jaw surgeries if needed in post-delivery can be considered after 15 to 16 years of age. Macroglossia is a condition where you will have a big tongue. Macroglossia, so big tongue. So it can be either true or relative. True is when there is a histological abnormality is present. Relative when the tongue is normal, but it is large due to the underdeveloped jaw or the oropharyngeal hypotonia. This condition also will cause polyhydramnias widely because the baby will not be able to swallow the fluid which is present around it, and it has got high association with overgrowth syndrome and trisomy 21 and inborn error of metabolism. And prenatal testing is definitely needed. C-section is preferred and exit procedure will be needed. And treatment option will be partial glossectomy, post-delivery, and secure the airway. So this is a very interesting case that we have seen in our center. It's oropharyngeal teratoma. So this particular baby presented with this facial profile where we can see a big irregular mass that can be seen protruding from the floor of the mouth. And this patient has decided to terminate the pregnancy, and the postnatal picture can be seen where there is a very big irregular mass can be seen. So it looks more like a teratoma, and HPE has been sent, and we are waiting for the report. And this usually has carries a poor prognosis because it will cause severe obstruction of the upper airway and high mortality rate during the neonatal period. And definitely in antenatal period, they will present with polyhydramnios because of the obstruction. And it is usually a developmental anomaly, no genetic etiology or recurrence risk is expected in this baby. So after the birth, how can we say we can debulk the lesion with airway support, and we can have the HPE and follow up the baby accordingly. This is an oropharyngeal ranula, which is also seen in our center. So it is caused because of the disruption and blockage of the salivary duct. It is usually non-lethal. It is developmental and no genetic etiology. Antenatally, it will also present with polyhydramnios. C-section is preferred and exit procedure will be needed. Treatment option will be just observe and treat. If airway or feeding difficulty is there, aspirate, excise, or marsupilase, sclerotherapy, cryotherapy, whichever is feasible for this particular baby can be carried out. So we have finished the forehead, we have finished the eyes, we have finished the ears, we have finished the mid-face, we have finished the lips and palate, and we have finished the mandible. So we have finished everything. Thank you for your patient listening, happy learning, and see you all in session 6. Thank you.
Good presentation.
Fantastic. World went through facial anomalies.
Thank you, madam. Thank you, madam.
Nice. Yeah.
Thank you.
Tamil, you want to add something? That binder's facials actually, we did an amnio center that tested positive for contour dysplasia punctata,
Yes.
which was presented there. So I think we had 5 or 6 cases of binders which tested for CT, for single gene disorders.
Okay, ma'am. I think we are running
Very nice talk, Riti, and very fast also, Vaigi Express. You have covered everything.
Yes,
Very nice.
Thank you, madam. Thank you, madam.
Thank you.
Thank you, all the speakers. That was very wonderful. We'll move on to the next session, which is the panel discussion on facial abnormalities. I request the moderator, Dr. K. Manigandan sir, lead consultant, fetal therapy, the fetal clinic in Pondicherry. Postdoctoral, he's done the postdoctoral fellowship in fetal medicine, Mediscan Systems at Chennai, and he's a former associate professor of Obs and Gynae in JIPMER, research fellow in fetal medicine, King's College Hospital, and he has done special training under National Teacher Training Course for Teachers of Higher Education, JIPMER, and he's also done quantitative methods in clinical and public health, and statistics and epidemiology training from Harvard. Welcome, sir. I invite the expert, request Dr. Ramani ma'am.
She won't be joining because of some commitments. She's unable to join.
All right. I request the panelists, Dr. Usha Nandini is also a consultant fetal medicine from Tiny Hearts Hospital, Tanjavur. She's done her MBBS at Thoothukudi Medical College and Masters in Ultrasound from Mediscan, Chennai. Fellowship in Fetal Medicine, Sydney, Australia. Research fellow in fetal cardiology. And she has also had genetics training and fetal medicine certification at London, and has done an MBA in hospital administration. And she's been a university topper and a gold medalist also. Okay, I invite Dr. Revathi Chandrasekharan, who's presented us with an excellent presentation just now, and I invite Dr. Reshma Marineni, who is also a fetal medicine consultant and fellowship in fetal medicine from Trichy since September 2003. And she's from Mysore and Karnataka. She's done a diploma in OBG from Mysore, Karnataka. The next speaker, Dr. T.P. Prathipa. She's done her MBBS from Madras Medical College in 1999 and MS OG from Pondicherry, 2006. She's a diplomate of National Board of Obs and Gynae in 2009, and she's done a fellowship in fetal medicine in 2012, and also a reproductive medicine specialist since 2010. And she has her own fetal medicine center. I invite Dr. Vijay Jagannathan, who is a professor of plastic surgery at Cherry Institute of Medical Sciences, and he's been working from Meenakshi Medical College Institute, and he's done a senior residency from JIPMER, and he's worked in various colleges. And I request you to join the panel discussion, sir. And Dr. Lalita Krishnan ma'am, who is a neonatologist. I invite madam, who is a consultant neonatologist and head of Department of Pediatrics and professor of neonatology, PIMS at Kalapet, between 2013 to 2021. She's completed her DNB in pediatrics from 1982 to 1985, and a DCH from CMC Vellore 1981 to 83. And she's done her MBBS from 1972 to 77 in Christian Medical College Hospital, Vellore. And she's a life member of National Neonatology Forum and Indian Academy of Pediatrics, and associate member of MRCPCH. Welcome, madam. We welcome all the panelists, respected panelists, to this forum. So we will start the panel discussion, please.
So Manikandan, welcome to you. A fantastic teacher, a very good friend, and a very warm welcome to other panelists, and especially Dr. Lalita Krishnan. She's a perfect neonatologist as far as I can remember. Welcome, madam. How are you, ma'am?
Thank you, Malti. Thank you. I'm fine. And I'm glad for this opportunity to join your forum.
Thank you, Thank you, madam. Over to Dr. Manikandan.
Oh, sir, we are not able to hear you.
I think you're muted.
And also, please share the slide, sir, if you have any.
Yeah, my slide sharing has to be activated. Is it audible now?
Now it's fine, sir. Now you can start sharing.
Okay. Hold on. Yeah. Right. Thank you, first of all, to TNFOG for this opportunity, but also more importantly for this wonderful initiative of spreading, imaging. I won't say awareness, because most of the obstetric practice, as I go to other parts of India, I see that the interaction between fetal medicine and obstetrics, especially the utilization of fetal medicine by obstetrics, is far, far high in Tamil Nadu. I was just discussing yesterday, I am here in Gujarat for a national brain conference. And when I interact with other people, I find that in Tamil Nadu, the way obstetrics handles fetal medicine is far better. Now, panel discussion is where different minds come together, and the same problem can be seen in different views, but also it introduces the concept, very important concept, that was introduced to me by Professor Lalita Krishnan when I started my fetal medicine practice, what we call multidisciplinary team consultation for the patient. So when a mother is confronted with the terrible news of the fetus having a problem, there are so many things that go into their mind. They start imagining monsters, the worst possible outcome. They dig up social media, they dig up Google, and end up in a very bad situation. And none of us should take the onus of clarifying everything to the patient. So in that way, panel discussions is like a forerunner for multidisciplinary counseling, and I warmly welcome, apart from Professor Lalita Krishnan Madam, Vijay. Vijay is my friend. He's a plastic surgery professor at PIMS now. And also all the rest of the panelists are fetal medicine specialists. Usha, Nandini, Pradeepa, Revati, and Reshma, good friends. So let's move on to the case discussion. And the first case, is my slide visible?
Yes, sir.
Thank you. So the first case is a patient who was referred for suspected unilateral cleft lip and right mild renal pelvic ectasis. So the original scan was done in a trained fetal medicine center only, but they had a doubt as to whether there is extension to the palate or not. That was their question, and so they had referred to us. She was a primee, but married for about 6 years, had tried a few IUIs, didn't conceive, planning IVF, and then given up because of affordability issue. And nothing else is significant except that they are consanguineous. She has been on aspirin 75 OD because of her bad history, started empirically by the obstetrician, and first trimester screening was unremarkable. So let me start the discussion. Let me invite Rashmi. Are you there?
Hello, good evening, sir.
Good evening. Rashmi, can you identify the image? Is it there on your screen?
Yes, sir. Yes, sir. I can see.
Yeah, you can just lead us all through the image.
So this is a coronal view of the nose chin view, which Dr. Lakshmi has mentioned. This is the routine which we have to do on each and every fetus. The routine view that has to be taken. Here we can see that a bilateral cleft of the lip, both lips, there is a defect. Upper part of.
Excellent. So the initial suspicion outside was unilateral, but it is very clear that it's not unilateral cleft lip, it's bilateral cleft lip. So what is your thought process? What do you want to do next?
So once we finish the routine nose chin view and seeing the upper lip, the continuity is not there. And when there is a cleft, next we have to see the palate.
All right. So before that, we have taken a surface rendering of the 3D just to communicate to the parents who have come believing that there is a unilateral cleft. We have to show them that it is not unilateral and bilateral. And this is a 3D surface rendering showing that on the right side, it is a prominent one. That's what has been picked up by the referring physician. And there is a left side, a much smaller cleft of the lip. All right. So this is a small clip, and I would like Pradeepa to comment on the clip. Do you agree with the findings of Rashmi?
Yes, sir. I feel the left side is more prominent in this clipping actually, and the labia is also separated. The clip is not actually running for me.
Oh, okay. So when we see in 2D, right and left is difficult to tell. So that's why the 3D is important for side identification. All right. All right. Now, Pradeepa, stay back. And this is the axial view at the level of the maxillary arch. Do you have any comment?
You're asking me, sir?
Yes, Pradeepa.
Yeah, okay. I do see a break in the alveolar ridge there. 2-point break is there. Only a central alveolus is
intact. Yes.
They are both right and left are there is a gap there.
All right. So what is your comment on the posterior bony palate, Pradeepa?
Not able to visualize the arch of the posterior palate, sir.
Yeah.
So must be extending into the posterior palate as well. Not only the labia or the alveolar ridge, but the palate as well.
Thank you. So we see breaks here. So these are the lip clefts. And then there is the central premaxilla that is intact, but there are breaks here in the alveolar ridge. So there is a cleft lip, alveolus, but if you carefully see, the palate is also cleaved here, which is like a inverted V. So final diagnosis, Pradeepa?
Bilateral, complete, cleft lip and palate.
So CLAP,
labial,
bilateral.
alveolar, and the palate is also involved.
Okay.
Bilateral. So
yeah, let's quickly go to the whirlwind Revati. Revati, are you there? After the whirlwind presentation. My God, how can you talk so fast?
Sir, I need to give you the opportunity to talk. So I finished my talk faster so that you can have the time all for yourself.
Thank you very much. So go into relax mode and tell me what you want to work up for this case now?
Okay, sir. So the workup will be like, before I will disclose this thing to the parents, I need to see the baby in total. So I have to see whether the
Ask me.
sir, whether complete anatomy of the baby has been done, sir. Are there any associated anomalies you could pick up?
There was none.
None. So this is a case of isolated cleft lip and palate. So isolated cleft lip palate. Now I have to start my first. I have to start my counseling with the parents. I have to make the couple sit down, and then I have to tell them, break the news that there is a clefting in the lip and the palate, and this could be associated with syndromic things. Even if it is isolated, it is associated with chromosomal abnormalities and syndromes. So they will be needing further prenatal testing that I have to tell them, sir.
Yeah, Revati, one request I am going to ask you is, we will be breaking the news, all those things. Okay, now tell me what test you want to do.
So I will be I'll be needing definitely a chromosomal aberration test. So I'll be asking them to go for a chromosomal microarray and a FISH.
Okay, so we want a test that will rapidly tell us whether there is the common trisomies. So FISH is an option, but currently QFPCR preferred. So one test is we will do a QFPCR, and then we will do a test to look at the chromosomes. So do you prefer a karyotype or do you prefer a chromosomal microarray?
Chromosomal microarray will be more sensitive, sir.
All right. Now, do you also, chromosomal microarray will tell us only to the level of chromosomes, but not single gene disorder. Do you want to test for single gene disorders?
Single gene disorder, I would say this is not associated with any other abnormalities except for this particular anomaly. So I would just tell them that it is not associated with other abnormalities. So since it is isolated, a chromosomal testing will be
Sufficient.
much enough. But yes, sir.
All right. So we have here a baby which is otherwise clean, carried by a parents who have been trying for 6 years, and there is bilateral cleft lip, alveolus, and palate. And then we have we are thinking in terms of doing an amniocentesis. Now, at this point, if I propose amniocentesis, and the discussion will go into what if it comes negative or what if it comes positive. So do you think the defect is correctable?
Sir, yes, it is correctable. It is not an uncorrectable one, but provided this correctability will also carry its other effects like speech abnormalities.
We have experts on the panel. We think it's correctable. So yes, when we think it's correctable, so that much idea when we have, then I think it's fair enough for the little one to get the expert on board. So firstly, I'm going to go to Vijay. Vijay is a plastic surgeon. Vijay, are you there?
He was there, I think.
Vijay, I shouldn't have stopped Revati saying that there is a expert on the panel.
So
Vijay, you let me.
Vijay,
you let me down. Okay, so coordinator, please call Dr. Vijay. In the meantime, I'll go to Lalita madam. Madam, when the baby is ultimately born at term, hopefully we expect this baby to go to term without any problem. What are the challenges faced by the parents when the baby is born with a cleft lip and a palate?
Okay, good evening to everyone. Now, one of the classic traditional teaching when we were medical students, if people may remember from Bailey and Love and all that, when we did not have fetal medicine and did not have ultrasounds, was the sudden appearance of this baby with this cleft lip and palate. And nothing is more traumatic. You can have transposition of great vessels, TAPVC obstructed, but the child looks normal. Parents don't care about that. Parents do care about how the baby looks as soon as he's born. So a cleft lip and abnormal genitalia, that really bothers parents a lot. Now, having said that, the challenges as a neonatologist, I think Dr. Manigandan, for the next few cases except cataract, I would sum it up so that I don't repeat myself at every panel.
Madam, I request you to withhold that exercise. We need you in small doses only.
Okay. So basically what happens is any of these facial anomalies, two things are important. Breathing, airway, breathing, and feeding. So these are the challenges that the neonatologist has to address. So there is no question neonatologist has to be present at delivery. Establish airway, make sure the breathing is okay, and how we are going to feed the baby is what we have to discuss with the parents. So in a nutshell, this is what is important.
Okay. We will go into the specifics of that, but again, we have Vijay back after a short technical thing. Vijay, if the parents ask, will you fix this defect or not? Do you give a simple answer, or do you say maybe depends, like that?
Sir, good evening, sir.
Good
Hello.
evening. Yes,
Sir, am I
Vijay.
audible?
Yes. Yes. Y- Vijay, you're audible. Okay. Again, some technical issue. Okay, madam, one of the things that parents actually in this case asked was, they have seen some YouTube videos and they said, when we feed the baby க்கு பொறையேறும். So whenever we say what I have observed is whenever we say it's fixable, then they'll come with counter questions. No, this I've seen, this I've heard. So how do we address that issue of feeding? That seems to be the more important thing in their mind.
Yeah, it is in the parents' mind and also for the neonatologist and the plastic surgeon, because the baby has to grow a certain amount before they even attempt surgery. So feeding is important for all the specialties. The parents' uppermost concern, one of the first things that happens we face is the expense that the baby has to have when it is in the NICU. Because first thing that we cannot do is send the baby to the postnatal ward, because if feeding is not established, we will have problems with aspiration. So it has to be tackled. Now, there are different ways. Of course, in the NICU, it's very easy. Put in an NG tube and feed the baby. But that's not the baby's life. We have to get on with it. So we have different techniques. And from day one, we start discussing with the plastic surgeon what we are going to do regarding the feeding. So that gap in the cleft has to be addressed. It could be by means of an obturator. It could be a Haberman's nipple, which is a long nipple which goes to the back of the throat with something called a squeezy bottle. In certain cases of cleft palate, without cleft lip, actually the baby can hold the breast and he can feed very well. The last but not least is palade feeding. But again, that has to be done with trained hands, and mother and at least one more relative has to be taught in the NICU how to handle a feed with a palade. So there are multiple options available depending on the extent of the anomaly and what the baby can do.
Okay, so is there also a need for a trained feeding specialist to be involved? Is there a tribe called lactation nurses who are trained in this?
Lactation nurses are typically trained in breastfeeding and lactation, but you can have nurses who are specialized, and sometimes they work with the plastic surgeons. Sometimes they work with the dental surgeons. You have nurses trained in that, and you have physiotherapists. There's a brand of physiotherapists called neonatal physiotherapists nowadays, and they are trained in feeding these kind of babies and also the preterm babies. So they dedicate themselves to feeding of babies. So you have multiple specialists who converge at one point, but the goal is for the baby to gain adequate weight in the neonatal period.
Okay, so these are the challenges faced by the parents, and that could be overcome by the neonatology input. Do we have Vijay back again?
Yes, sir. Sorry again for a timely break. So first of all, thank you for inviting me to be this panelist. And I worked with Lalita Madam. Lalita Madam knows me, and she was instrumental and the pioneer in starting the CGRC Center in PIMS, which is a wonderful, a great establishment in the treatment of pediatric plastic surgery patients. So it was a very novel idea for us also, but we are very happy to come into contact with the neonatologists, psychologists, speech therapists, ENT specialists, and pediatrician all at all at one place. And we are very happy when fetal medicine specialist also joined. So the whole gamut of pediatric plastic surgery was picking up very well due to Lalita ma'am. Sir, with regarding to this case, yes, madam has answered the initial part of the management. When we are sitting for a counseling, of course, the parents will be scared that probably a monstrous child is going to be born, and what are the probable hardships they have to face in probably trying to convert this mal-appeared child into a normal one. So in this particular case, if you see, there is a bilateral cleft lip, there is a bilateral cleft palate, and of course the alveolar arches are also clefted. So this is a bilateral cleft lip. If it had been only cleft lip, then we can tell like initially the feeding hiccups will be there, which can be treated by lactational nurses, or asking the parents to give a proper position, like feeding at a 45 degrees, and not to be scared of feeding at 45 degrees, or take a Pala-day feed, etc., or long, wide nipples with a wide hole at the tip. These are the few things which we advise the parents, so that the initial feeding part can be taken over. When it comes to the surgery part or to the correction part, we have to tell them, or we have to give them a whole, a brief idea about the total, the timeline of various surgeries. That is the most important thing. So when you take the timeline of surgeries in cleft lip and palate, most of the cleft lips should be operated by 3 to 5 months. And only by 3 to 5 months, they gain a hemoglobin of more than 10. Their weight becomes better, and 10 pounds they reach. And the anesthetic complications are also relatively less. Though we have a lot of neonatal anesthetists, still widespreadly up to 3 months, most of the anesthetists are a little bit dicey about the results in extubating. So 3 to 5 months will be the ideal time for the cleft lip repair. So that is what we have to tell the patient. Like at 3 to 5 months, your child has to undergo one surgery. The second part of the surgery is the palate. In Indian setup, only a cosmetic disfigurement is still very easily correctable. But if a patient is not able to speak, their livelihood is spoiled, their education is spoiled, their communication skill is spoiled, and there is a social stigma that this particular person cannot communicate. So that has to be corrected earlier. So most of the kids pick up the monosyllable words due to the palatal movement by 9 months to 11 months. So what we plastic surgeons and pediatric plastic surgery team advises, do a palatoplasty surgery by 9 to 11th month. So this is the ideal time. Again, we convince them, there are some centers which tell if the baby is relatively big, we can do a better correction because the structures are better. But the problem is, anatomy is clear. But the problem is, once the child goes for a mislearning or mal-learning, it is a problem. So the palatal surgeries should be done by 9 to 10 months.
Okay. So is it enough just to correct the gaps in the lip and palate, or you have to train the palatal muscles? Do you have to introduce speech therapy also?
Yes, sir. Yes, sir. Definitely, sir. Only palatal surgery is not going to bring the result. Again, speech is a three-pronged process. First, the child has to receive, then the child has to process in the brain, then the child has to give an auditory input. So speech is not the only aspect of a palatal. It is not only the function of palate alone. So we very well tell all these patients, there are chances that they can have a subnormal development. There are chances they can have a ear problem, and there are chances that even after palatal anatomical correction, they can have a functional correction. So we pretty much tell them that it's not a magic that after 9 to 10 months, once you anatomically correct the palate, the child is going to have a clear-cut speech, because input, processing, and output should be assessed well. So its speech therapy will be introduced. In fact, in CGRC, we introduce them to the speech therapy. The speech therapist tells, like, by 2.5 to 3 years, we do a thorough speech assessment. We assess their entire speech, and we start the speech therapy with or without palatal surgery. Whether we are doing surgery or it's post-op or pre-op, speech therapy is must. And it's better to stick on to one team because they'll be knowing how to take the child and where the child was and where the child is now.
Correct. So the child also gets used to the team and the team gets used to the child. They become mutually friendly. All right. Now I have a concern because there was cleft extending through the alveolus also. Will there be issues like malocclusion and crowding of the teeth?
Yes, sir. Yes, sir. Sir, with the alveolus, the alveolar gap is usually taken care of in two methods. We either do a primary alveolar bone grafting or a secondary alveolar bone grafting. Primary alveolar bone grafting is only theory level. Most of us do a secondary alveolar bone grafting. Also, we call it as SABG. Most of the time, if you notice, the cleft is between the premaxillary component and the lateral canine. So, what is affected usually is the eruption of the canine. So, the eruption of the canine is somewhere around 7 to 9 years of age. So, what we usually do is we screen the patient's X-rays from 7 to 9 years. Fine. We do the alveolar bone grafting before the canine erupts. So, if you bone graft it at that time, the canine correctly erupts and doesn't become malaligned.
Okay.
So, alveolar bone grafting is a procedure which most of the time we suggest. Mostly it is between 7 to 9 years. Scientifically, it is before the eruption of the canine.
All right. Well, even in those who have got a good correction, no, sometimes when I see when they come as mothers, I see that the nose points down like this sometimes.
Yes, sir.
Now,
Yes,
is
sir.
that a correct observation or is it one-off
Yes, sir.
event?
Yes, sir. Correct observation, sir. No, sir. It's a very correct observation, sir. So, first of all, we are doing the lip repair at 3 months of age. Most of the kids, they have a protruding premaxilla. What is a premaxilla? Premaxilla has a bony component and it has a soft tissue component. The bony component are all the palate anterior to the incisive foramen, the alveolar arch associated with the primary palate, the upper 4 incisors. Whereas the soft tissue component is the philtrum and the columellar part also. So this retruded or shortened columella is a very striking feature of especially bilateral cleft lip, sir. So because most of the time while doing the surgery, the philtrum is recreated by raising the prolabial flaps. While doing so, the columella gets shortened. So there has been a paradigm shift from soft tissue repair to cartilaginous repair in plastic surgery field, whereby this particular complication of columellar retrusion or shortening has to be corrected. Basically, the tip of the nose is short because the columella is short. That is the actual pathology, sir. Sir, I would like to just supplement this answer. Nowadays, for all these, we do realize that it is becoming a long-term complication. So the best method to correct the cartilage is by doing a NAM, naso-alveolar molding. So naso-alveolar molding is a technique wherein we give silica or other molds to the nose and we expand the cartilage and we also lengthen the columella. Unfortunately, NAM is very effective only if it is done in the first 6 weeks to 8 weeks of the kid because the maternal estrogen crosses to the child and the cartilage is pliable only at that time. But unfortunately, we are in a situation we don't get the NAM care, and that is why actually if NAM has been applied and the columellar cartilage has been expanded in that particular 6 weeks period itself, the long-term complication of a retruded columella won't be there. But unfortunately, only in Changun Memorial and other Korea, wherein the craniofacial cleft team is huge and they have a good center, it is being done properly, sir.
All right. Now, both of you have seen patients after the in utero period, both the neonatologist and Dr. Vijay. And from what we have discussed, I understand that when we make a diagnosis of cleft lip and palate, especially cleft lip and palate, there's going to be a series of interventions, surgical interventions for the baby. Now, based on your experience of treating such children, how do the parents take it after they go through this long drawn process?
Actually,
how do the children?
I know, sir. Sir, actually, they become family friends. That is the truth. Only because right from the childhood, we have seen the growth of the child. They come for follow-ups. It becomes all their, summer holidays. No, it becomes a very good trip, nice trip to meet the doctor who treated them. So they are good with us, sir. The problem comes with the money, sir, economy part. If the family is well-to-do and can support, then they can make the recurrent visits and undergo all the splint correction, physiotherapy, speech therapy, etc. But that's where we are what do you call? We are not able to make the ends meet there only, sir. So they do take it. They do
All
have a
right.
fatigue. But the thing is, once the lip is corrected and the child is looking normal, most of the parents are very happy. All the other
Motivated.
corrections like the alveolar, yeah, they are very motivated. All the SABG, palatal correction, speech is mainly for plastic surgeons and OMFS surgeons. But most of the patients, the parents are happy. The next problem comes only 3 years when their child is having a staccato speech. The words are not there. There is a difficulty in understanding. Then only they little bit get depressed that their kid is not able to speak normally. But we do the counseling, and when they pick up, it's better. Only those in kids, those who don't pick up, there is a problem, sir.
All right. All right. So this was essentially a sort of multidisciplinary counseling that we do in our clinic whenever we make such diagnosis, which should involve postnatal physicians. I refrain from giving good prognosis, bad prognosis to the patient. So I involve the neonatologist, the pediatric surgeon, and the pediatric plastic surgeon or pediatric cardiologist, as the case may be. So I thank Vijay. Vijay, thank you for your valuable time. For the rest of the discussion, it will be more of fetal medicine and neonatal. So thank you, Vijay.
Thank you, sir. Once again, thank you for giving this wonderful opportunity among the stalwarts of fetal medicine. I'm also happy that the first pediatric plastic surgery conference was held only this year. As a fraternity, plastic surgery is a very broad field, and now pediatric plastic surgery fraternity is forming a good cohesive unit. And the first pediatric plastic surgery conference was held in Kerala, and our postgraduate only was the organizing secretary, and we are looking into collaboration with all the fetal medicine specialists. Later on, I would like to call you and other fetal medicine specialists for such conferences also, sir. Thank you. Thank you for the opportunity.
Thank you, Vijay. Okay.
Thank you, sir. Thank you, ma'am. Lalita, ma'am. Thank you, ma'am. Bye.
Let's move on to case number 2. Pradipa, I have this patient.
Yeah.
She is a second gravida. The previous patient, the previous baby is alive and was diagnosed to have congenital cataract after birth. Surgery was done and vision is normal. Now, it's a non-consanguineous couple. Do you expect congenital cataract to recur?
It's a non-consanguineous marriage, and autosomal dominance, for familial and autosomal dominant patterns are so probably
Can be there.
yes.
Okay.
Can be there.
So anything you want to do while taking history?
Ask for history of infections, ask for history of family members being affected, and do a pedigree chart and try to analyze what kind of inheritance pattern is there.
There are, we did the pedigree and 7 instances of congenital cataract in the family. And it was autosomal dominant pattern. So how, what do you feel when you are going to take the probe and scan?
Definitely have to look at both the eyes and go in for an actual section of the eyes and try to find out.
Okay,
look
so
at the orbits.
Here comes
the
here comes the images.
Okay.
Mind you, this is at 32 weeks. Can you interpret the images?
So the right or the left part of the image appears okay. One of the orbits in the lens is translucent and it's okay. But the other side, the lucency is increased. There seems to be a cataract on the left side.
Okay, now look at the clip now and see if you're going to have a different opinion about the left eye also.
The left does. So this is the left eye, yeah?
Yeah.
The clip of the left eye alone.
Yeah, yes, correct. The one which we thought was clear, is it really clear?
No, sir. One of the surfaces seems to be echogenic as well.
Correct. Now the patient, no?
One of the, or probably the anterior surface appears to be echogenic as well.
Yeah. Reshmi, are you there?
Yes,
Yeah,
sir.
the patient immediately pounced on me. She said, I came to you from target scan onwards. Why are you telling me now? What should be your answer, Reshmi?
So, usually it can also be the evolving thing, sir. That is one thing. And especially when there is a family history, we also need to look for the gene testings.
Okay, so
We also have to
uh,
exclude other
the,
craniofacial abnormalities.
the mother is there, the previous child is there, all had congenital cataract, operated. Mother is quite intelligent. First child is also intelligent. My question to you is, will you definitely do the gene? I mean, is a must in the managing this patient?
So when the family history, yes, sir.
Is a must.
Yes, sir.
Revati,
So
will you always do gene testing in this case?
the gene testing is needed when you want to prognosticate something. So, like for
No,
example,
no,
this
in this case, no.
yes,
In
sir.
this
In this
case,
case only, I'm telling. To
yeah,
prognosticate something, you will definitely need something called gene testing. But then this
correct.
parents are carrying there are multiple histories in the whole family. First child has got the same thing, but everybody is having a normal mental health, and everybody has got corrected with the thing. So, like, if you would ask me, definitely need a gene testing. If at all it has been transmitted to this particular pregnancy, also this baby is going to be mentally good as like their parents and the previous child, and I'm not expecting anything more than just a cataract in this baby.
All right. So, what Reshmi was telling was to make an early diagnosis, you need genetic testing. And as you said, by doing a genetic testing, the prognostication is not going to change in this case. So I asked her the question when she came at target scan, will you abort if I find congenital cataract recurrence in this child? And she said no. So Reshmi, will you now press on a genetic testing?
Hello.
Yeah, Reshmi.
Yes, sir.
So she was not ready to terminate the pregnancy even if I made an early diagnosis. So is a genetic testing required to manage this pregnancy?
Sir, one thing is we have to see whether it is only isolated or associated. But sometimes, because mostly congenital cataract will be associated with n number of
Okay,
symptoms.
I'm going to stop you there and look at the history. There are 7 instances of congenital cataract in the family. So are we
All
going
the
to
babies are
expect
normal.
a fresh new? Yeah, normal. In fact, the mother had and the previous child had, everybody had.
Oh, okay, sir. Then in such instances,
There is no need for a genetic testing to prognosticate congenital cataract in this family, isn't it? It's
yes, sir.
the simple garden variety congenital cataract and can be fixed. So we'll go with Revati's answer. In a case where the parents are not ready to terminate, early diagnosis of a congenital cataract is of limited use. So I told the lady that congenital cataract can manifest later in pregnancy or even postnatally. So ultimately, she was able to come to terms with that, and then she delivered a boy baby, very beautiful boy, had operated at Pondicherry Arvind Eye Hospital and is doing now well. Let's go to the third case. Okay, before that, Lalita madam, any specific management of congenital cataract in the newborn?
No specific management, surgery is the only option. But to detect congenital cataract, now there is a test called red reflex, which must be done for all babies at discharge. Now, that is often not done in many neonatal units. I know fetal medicine is giving us a warning about congenital cataract, but you may not get that warning all the time. So, I
Correct.
would request obstetricians to make sure that their babies at discharge have had a thorough examination by the pediatrician, including a red reflex, because delay in surgery will lead to blindness. So,
Oh,
it is
okay.
important that at the right time the surgery is done, otherwise the child will not fixate and smile at the mother and things like that. So
Okay.
other milestones get affected. Now you all were discussing about whether gene testing. Now if the mother is having a tubectomy after this delivery, perhaps we wouldn't do a gene testing. But remember there are other inborn errors that can also take place.
என்ன மேம் இருக்கேன் இங்கதான் இருக்கேன் இருக்கேன்
I can
இப்படியே போட்டுருவோம் டக்குன்னு முடிச்சிருவோம்ல முடிஞ்சோடனே
all the other
ஹலோ
features
கேக்குதா
we
மேம்
should not assume that it is the same familial cataract, perhaps at least after birth. We should
Yes.
make sure there is
Yes.
no other.
If a neonatal examination, if it's raising any other doubt, then obviously we will test for other causes. All right.
Because
So
some inborn errors, like galactosemia, you can have
galactosemia.
others which
Yes.
do not have physical manifestation. So
Correct.
one needs to be,
One question to Dr. Manikandam. So when we look for this congenital cataract, we find the gene and we do a series amnio to detect in the present pregnancy. It's not a lethal issue, right? So we're not going to terminate the pregnancy just because she's tested positive.
Yeah. We
So what do
if we yes, madam.
can be corrected?
Question. If we know the natural history of congenital cataract in that family, for example, all autosomal dominant congenital cataract are not simple. If it is associated with microcornea, so cataract with microcornea, then it's a totally different issue. The correction and the vision will not be one-stop process. It's a lifelong suboptimal vision. So the parents may want to consider termination, even though the first baby is okay, is doing well. They may not want to suffer with the second child.
Yes.
So
Sometimes they may have a flow. Yeah.
Correct. The first question that we always ask before we initiate a genetic workup, we always want to work up genetically. I fully agree with Reshmi and Lalita madam. But the first question we ask is, if it turns out to be a genetically positive child, affected child, will you terminate after understanding? If they say yes, then only it is worthwhile to start genetic testing in the prenatal period because of the uncertainties. Shall I move on to the next one?
Yeah.
Okay, so again, we'll start with Pratibha. Pratibha, there is a bilateral.
Dr. Usha Nandini also is there. Dr. Usha Nandini also.
Sorry. Usha Nandini, sorry, ma. Totally skip because I'm not able to see anything else other than my screen. Okay, we'll start with Usha. Usha, this is a case, second opinion for renal pelvic cases and echogenic focus. The the garden variety ready for amnio. Okay, 2 markers. Previous history unremarkable. Preterm, PPROM and preterm birth. Otherwise, baby is doing well. And this time, she has not undergone a first trimester screening. All right. Now, these are the images. Can you interpret that for the audience?
Dr. Usha, are you there? Dr. Usha Nandini?
Yeah, I'm here.
Usha Nandini, first apologize. I accept my apologies. I could not see anybody on the screen. Sorry,
not at all.
Come to the center. Come to the central screen.
Yes.
You have to adjust. Yes, right.
I'm not able to see anything.
Yeah, can you see me now?
Yeah.
Now we can see. You need to come more to the center.
Yeah.
Yes, that's right. Yeah.
Fine. Yeah. Yes, sir. Go ahead, sir. Yep.
You go ahead.
I'm
unable
to see
okay, it's a mobile. You're on mobile.
Yeah,
No?
I'm using my mobile. I have been moving around, so
you're not audible. You're not audible, Usha.
Ma'am, I'm able to hear you. Can you hear me now?
Yeah.
Yes. We can hear you now.
Yes. Yeah.
So interpret the images. This is it's otherwise a
the
routine target
actual,
scan.
And one orbit looks normal to me. The other one in this section at least doesn't look really normal to me.
Okay, so what is your concern?
Whether it's a small globe or is it any kind of microphthalmia?
Okay, so obviously there is a size difference, isn't it? So we need to dive deeper into this.
Yeah.
Okay, so I have got some more images, transvaginal. and a little bit more oblique axial.
Looks like I could see the lens, but still the globe is small, so it's like
Yeah.
more like a microphthalmia to me.
Yeah.
And
So, what is your comment on the posterior chamber of the small eye? Does it look okay?
Looks more hyperechoic.
So we are not happy with the posterior chamber.
Yeah.
So
Yes.
what will be your comment or take on the vision part of that eye? Even though it's small, do you think this is going to work?
I think that could be uncertain. And that's what I feel, and I would call this as. I mean, we have to wait and see, like more like whether the vision could be compromised in that
Yes.
So-called abnormal eye.
Correct. So once we see the posterior chamber not good, that is a chorioretinal dysplasia, then the vision is unlikely to be normal in that. So this we explained. And do you want to have any workup on this child?
Yeah, certainly yes. And I think I'll ask more for the history and pedigree. Sorry, I'm not sure whether you gave me the history, sir. Is it?
No,
Yes.
I'm putting it there.
Yeah.
Non-consanguineous couple, pedigree, nothing.
Okay. But still, I would like to counsel on what all are the possibilities.
Okay, go ahead.
And I'll talk about whether the baby could have something abnormal in the genes or in the chromosomes as well. And I'll give the option of direct fetal testing.
Yes. What do you want to do? What are the tests you're going to order?
Ideally, I would say both chromosomal and genetic gene sequencing as well. So I'll explain if at all if the parents are keen, then I think we should go ahead with that.
Okay, now to all of the fetal medicine guys there, is termination of pregnancy on the table now?
So we'll have to discuss with the couple actually, whether they'll be able to face.
Before evaluation, we cannot terminate. We have to evaluate.
Pratibha,
Basically, by
is
evaluation
it there on the
should
table?
become. No, not at this stage.
Okay, what evaluation do you want?
Look at the other parts of the face. Look at
Other
rule out
systemic
major
abnormalities.
malformations.
I've given you all the findings. Rest is all unremarkable.
Yeah. Still, there is a possibility to have a single gene disorders also. That should be counseled.
Okay, so they agree to amniocentesis. If they agree to amniocentesis and you do chromosomal microarray, it returns normal. Do you want to undergo any further testing on the amniotic fluid?
Yes.
Exams. All exams.
Whole exome sequencing. Okay, so whole exome sequencing. Reshmi, are you there?
Yes, sir.
Reshma, what counseling will you give before you order whole exome sequencing? This is very important because many of the audience here is obstetricians. So we need to give a clear idea about what this whole exome sequencing is.
Whole exome sequencing is a detailed study of all the genes.
Yeah, why don't you activate your camera? I can't see you actually. Yes.
Am I
Visible, yes. Tell me.
So I'm doing from my mobile only, sir.
Yes.
The whole exome sequencing is a complete study of all the genes, and usually it will take the one thing is it will take a long time for the reporting. So that is one thing we have to counsel them. So depending on the gestational age, and based on the report, we will go ahead with the counseling apart.
Okay. So one of the important things that we should tell them is it is not the complete evaluation of the genes. The genes have coding and non-coding regions, and the whole exome sequencing typically looks into the coding part. You may have sometimes non-coding regions being abnormal. And also, that is not the main issue. When you do for a fetus. Yes, very good. Can you explain, Pradipha, what is VUS?
So we might have end up with variations of uncertain significances. Those are not pathogenic or likely pathogenic findings that we get in the report, but the clinical significance will not be explained.
Okay.
So
But
So
if
if
it
to
is
put
a
it
when
in
you
the
have a
we'll not be
VUS,
able to
if
prognosticate.
if it
hold on.
correlates
Let
to
me
the
explain.
phenotype.
Let me explain that. It's a very bad misunderstanding that has to be unraveled now. When we do for a fetus with very limited information, because in the fetus, we only have some ultrasound images with very limited images. In a case of, for example, microphthalmia with these findings, the chance that you will hit a pathogenic result in a whole exome sequence is only 2%. But the chance that you will hit a VUS, variant of uncertain significance, is about 30%. And what is VUS? VUS is only after the database says there may be a link. So don't take it by VUS, because the VUS itself means it is somehow the database links it to the phenotype that we have given. But it is not to be taken seriously unless we have further tests of function that we can do. And typically in a case of an eye or on a structural malformation, that is not available. If it's a case of an enzyme, if it's case of a metabolic disorder, then we may test the amniocentesis for that particular enzyme activity.
Functional studies and segregation analysis and all
Correct.
those things which we
So
need to
then
understand.
we may come. So going for a whole exome sequencing straight away in a fetus, I suggest keep very vigilant, because VUS pops up. Usually we'll put the blame on that and then the baby gets terminated. Okay, so let's go back to this case. And my question to all of you is that both CMA and WES has come back, that is whole exome sequencing and chromosomal microarray returns back as normal, nothing abnormal detected. Now the patient comes back and says, can I have a TOP? Will you even discuss TOP as an option?
Sir, if they are bringing up, I think we might need to discuss it, because they're going to be worried lifelong, but we're going to say it's not going to affect them in the survival part of it. And the rest of it, it's a functional problem that, like the vision or the functional problem that they're going to expect postnatally.
Is also a cosmetic problem, don't you think so?
Yes, of course. But the vision problem would be, yes, of course, all of them together.
In fact, if you have two eyes normally looking, and one of the eyes is
it doesn't mean that the vision is going to be normal.
One of the eyes is lacking vision, it may not be that bothersome to the parents or even the child, as much as when the eye is not working and also not normally looking. So based on this, if they ask termination, is it okay? Will you encourage that, or will you not encourage that at all?
Sir, I think it's the personal choice of the couple actually.
Yeah. So we should
give their personal choice. I can only suggest them that survival, or of course there can be some retinal dysplasias as well. I would just give them a non-directive counseling. It's up to them to decide yes or no, whether they want to raise the child or not.
All right. So in this case, we had advised them to undergo amniocentesis. As a policy, we don't offer WES unless we have a strong ultrasound phenotype of a syndrome. Otherwise, we say chromosomal microarray plus DNA storage. And if you are not willing to continue the pregnancy, send the baby for autopsy. So this is the standard counseling we advise. In this case, they underwent termination, no amnio, no autopsy. Okay. Is the usual scenario I face.
Excuse me, sir.
Yeah.
This is Dr. Navya here.
Hi,
And
Navya.
hi, sir. So I have a query on that. Like when we are reporting something, like when we see an obvious changes in the posterior chamber of the eye, is that right to write as a chorioretinal dysplasia as such without any pathological diagnosis? Because you are now telling that there is no autopsy findings also. So
All
it
right.
is better to write it as a posterior chamber abnormality with some kind of an hyperechoic area in that.
Yeah,
Because
we can write like that, no problem.
so because
Dysplasia in ultrasound world is commonly used to tell
exactly.
not histopathological correlation. Remember that whenever we say dysplasia in ultrasound semantics, there is no, in the vast majority, it doesn't correlate with histology. Tricuspid valve dysplasia, you would have given 100 times. There is no dysplasia in the valve. So dysplasia
yeah,
is
it
a term we
varies
use.
according to the place where we are going to report. But
Yeah.
particularly in this area, is that I have
It's
that
an
query whether
accepted
we can
terminology.
report that way.
Yeah, it's an accepted terminology in the posterior fossa. I'll show you in the posterior chamber. I'll show you other
Yes, sir.
other posterior chamber also. Don't worry. Stay with us.
Okay.
So in which case I'm going to go. Oops. I will go to case.
Case 3, no, sir.
Hold on. So we'll go here. No, sorry. No, sorry. All right, so let's go here. So this is a case who was sent at 31 weeks for suspected ventriculomegaly. Okay, so Usha, because Usha has been left out, I want Usha only to participate in this. Okay,
Yeah,
Usha,
sure.
these are the images. Come on.
So definitely the
Good,
head
bad.
intracranial structure doesn't look normal. It's abnormal. You measured something. I assume that it's the hugely dilated lateral ventricle, and I'm not able to appreciate the midline fox well in this.
Because you are using a mobile. Come on.
Can you hear me? Yeah.
There is a midline fox, and I have perfectly measured the lateral ventricle. It's huge. It's 31 millimeters.
Yeah, that's what. It's a huge lateral ventricle. And to the picture on the left.
Yes.
Yeah, I think it's one of the ventricles which is dilated in the midline, and I could see a portion of the cerebellum.
Yes. Very good. All right. So is it good or bad looking?
Of course, bad looking.
Or terrible?
Yeah, whatever you call it. Terrible.
So do we stop? Do we stop the examination here and tell them to undergo autopsy? I mean, sorry, termination, or do we want more examination?
Definitely, I need more examination. A complete fetal ultrasound examination.
Neurosonogram. Okay. So
Neurosonogram and systemic anomalies.
Facial imaging.
So before we obviously face. So Navya. Okay, she's not part of the panel. So Pratibha, you wanted face. Comment on this image. Now, let me ask you a directed question. So here, are you happy with the orbits?
No, sir.
No. Are you happy with one orbit at least?
One orbit is fine, yes.
Yes.
The second
one on the left orbit.
Yeah,
the posterior chamber is okay.
Part of the lens, and then I think there is a persistent, what do you call, the vitline artery is persistent, or what is the second image.
So this is also a posterior
the posterior part
chamber.
of the lens is also echogenic in the left side image, actually.
Excellent. So
one of the orbit is smaller. Sorry.
This is also posterior chamber abnormality, but here you can see that the retinal plate is okay. The problem is with the vitreous plate. Okay, so this we call it persistent hyperplastic vitreous. Now let me go on. Here you can see that there is a cone of tissue that goes all the way back to the retinal plate, and this is a persistent hyperplastic vitreous. Now neurosonogram, posterior, there was nothing anterior cerebrum, there was nothing, there's just huge ventriculomegaly, but this is the posterior fossa. You can see a small vermis, and all this arrow point towards the brain stem. Usha, anything? Okay, I'll give you a
The
clip, but
brainstem is
before that,
coning, sir.
yeah, it's not coning, it's
Pushed
like
into
a Z, right? It's like a Z. So before we go to the clip of the brainstem, this is for Navya. You can see that the size-wise, it's a bit smallish, but you can see behind the lens, the conical hyperechoic vitreous that keeps going towards the retina, surrounded by relatively okay posterior chamber. All right, so this is a clip trying to show the brainstem. Can you see the hypoechoic brainstem curled like a Z, retaining the embryonic flexures, the mesencephalic and the pointine flexures? Can you see here?
Yeah.
Yeah. Usha,
Yeah.
when you see this kind of eye and brain ventricle and brainstem, is there any strong phenotype?
Yeah,
Ultrasound
big walk and
sonophenotype?
wobber and all.
Absolutely, very good. So this one is the Walker Wobber, which Revati, when she was explaining about cataract, she just made one line. It could be a sign of Walker Warburg. It's actually true. So this is a case of Walker Warburg syndrome, and here the sonophenotypic features are good enough to make a diagnosis. They're specific enough in this combination. So Usha, do you want to tell something about Walker Warburg?
To be very honest, like I think it's more like, I mean, of course, genetic association is there, and I think what all the CNS features and eye abnormality. Apart from that, I don't think there is usually any other systemic association with this, and I would certainly advise direct testing for this.
Yes. Now, it's a autosomal recessive disorder, and it
Yeah.
principally affects the muscle, brain, and eye. In fact, it's called the brain, eye, and muscle disorder.
Syndrome.
And also, it's otherwise called as cobblestone malformation. So you will have lissencephaly, and on the pathology, you will have cobblestone picture of the
Yes,
cortex.
Hello.
Correct. Now, in this case, we need do we need a genetic evaluation, Pratibha, for next pregnancy management?
Yes, sir. Probably. How many weeks was the patient now?
Now
Yes,
she came at
the
31
genetic
weeks.
evaluation should be done actually. So that prenatal testing can be offered.
Wait for delivery and then do an exam.
Yeah, yeah.
Now that the
Probably wait for
pregnancy has
delivery.
already reached 31 weeks, we cannot prognosticate this particular pregnancy. So what we can do is we can deliver the baby, we can test that baby, and then prognosticate the future pregnancies.
Yeah.
Why not offer ultrasound diagnosis in the next pregnancy, Revati? Because we are telling that the picture is very specific for Walker-Warburg. So why not do it by ultrasound next time?
No, sir. No, we don't want this to recur again. We don't want the patient to wait till 31 weeks like how she waited this time for the next pregnancy. So I want to have a diagnosis now so that in the next pregnancy at 13 weeks, I will offer them a CVS and tell them the answer then and there, and then let them free of their worries.
All right. So when the manifestations of a genetic disease, even if it is ultrasound detectable, if the manifestation is going to be late in pregnancy, it is better to have a genetic test, genetic result in hand, so that we can perform a CVS and say whether the condition is recurring or not, isn't it?
Yes, sir.
Okay, so late manifesting genetic diseases, we need a genetic answer in the index pregnancy. That should not be omitted. Okay, very good. Okay, let's finish with
Excuse me, sir.
Yes, please. Who's this?
Yes, time's up, I think.
Yeah, I was about to finish it. Okay, we can finish it now.
All
So,
right. Okay.
okay, we can finish it. So
All
to
right.
summarize,
Sorry.
when we see clefts which are correctable, and when we see congenital cataract, which are the mild variant, then it's a good idea to involve the postnatal physicians, including the neonatologist and the pediatrician if you don't have a neonatologist, to give an accurate, non-biased counseling to the couple so that they make informed choices. I I recommend that the fetal physicians don't get very emotionally attached to the child and paint a very purple picture all the time. So give the non-biased, and also I request all the obstetricians also not to get anti-biased against the fetus or the pregnancy, thinking it's an anomalous fetus. So give the child a fair chance, give the parents a fair chance to get access to good information, and after that, after they understand everything, they can make a call. So multidisciplinary counseling is the current a standard of care whenever there is a fetal anomaly. Now, the second point that I want to drive home using this is that certain anomalies, when we encounter, we must try and evaluate the genetic etiology. For this, interaction with the fetal medicine specialist is very important, and they will be able to tell whether there is a high chance of finding a genetic anomaly, what kind of tests they have to do, and whether it is okay to do the test before termination, even if it's a bad case, or after termination. In general, genetic test after termination is not a good idea. All right. So I thank all the panelists for your wonderful inputs, and we can wind up here. Thank you very much.
Thank you, Dr. Manikandan. Thank you all the panelists for joining in the remaining. Yeah, thank you.
Thank you,
Thanks a
madam.
lot.
Thank you very much.
Thank
Thank you very much for the.
Thank you,
Thank you.
Malati ma'am.
Thank you. Bye.
Thank you, Manikandan sir. Thank you so much.
Thank you.
Thank you.
Thank you.
Confirm.